Bismillah
Okay,
wassalat.
shall we start?
Yes, just a little introduction. It's okay.
Okay. Yeah. شكرا جزيلا دكتورة على هذه المقدمة الطيبة, the kind introduction, and I'm really pleased to be with you to present something about the diagnosis, treatment, and vaccine development for visceral leishmaniasis. Can you hear me well?
Yes, we do.
Okay.
Allow
So
me to.
in this presentation,
Yes,
yes,
please.
in this presentation, I would like to give a bit of a background in the beginning about the disease, not in depth, but mainly about the highlight, the importance of the disease, the epidemiology, and I will put you also on a bit of immunology and clinical symptoms and signs explained by the immune response. And then we create a gap to present what is the gap in the diagnosis, what is the gap in the treatment, and also the vaccine development. So, why do we still speak about visceral leishmaniasis? I think this is a very important question. We have to answer it. So, visceral leishmaniasis has a huge global burden, and it is mainly a disease of children in the endemic areas. And this is a sign, by the way, of the endemicity, because if there is an epidemic, or then the disease will be, affecting across the population, children and adults and old people. And that reminded me with the story that narrated by Professor Al-Hassan to us, that when people migrated from one area of no leishmaniasis to another area in South Sudan, which is endemic for leishmaniasis, hundreds of thousands people died across age groups because they came in the endemic area and they are naive. So the disease was contracted by all of them, whereas in the endemic area itself, only children had the disease. And this is very important. So there is extensive regional variation in the clinical symptoms and signs, in the diagnostics, and also in the treatment responses. So the disease in Eastern Africa is different from that of India, is different from that in Brazil and South Europe. So this is a very important point, because when we are developing drugs, we used to when we develop some drugs, we use to see whether we can extrapolate what we found in East Africa to India or Brazil. But the story told us that there is huge regional variation, and that the drugs that worked well in India did not work in Eastern Africa. So that
Make
means
sure
we have, yes.
the slide share is not. We cannot see the slides. So
Yeah, I'm just speaking. You
okay.
can't see the slides.
No, we can see your screen, but not the PowerPoint.
Okay,
If you double click
so
on the PowerPoint, please.
okay, let me do that. Shall I share from the beginning? Better to stop it and share it again.
Yes, please.
Is it okay now?
Yes, that's perfect. If you go to slide
Okay.
show, make full
Yes.
screen.
the global burden of leishmaniasis, and I went through that the information that the disease in the endemic area is mainly affecting or affects children, and that there are extensive regional for we have to develop, for example, a medication or diagnostics for every region because it is different from one region to another. And the diagnostics are far from satisfactory. That is to say, they're either of low sensitivity or low specificity, or sometimes very invasive and very difficult to do it in the endemic area with bigger facilities in the lab and no trained personnel. And treatment are still orphan. We don't have any new chemical entity, but we are trying to combine the orphan medications like ventostam, promomycin, and other medications. So unfortunately, there is no licensed vaccine so far. And if you can see the map here, there are three main foci. Eastern Africa, which includes Sudan, Ethiopia, Eritrea, and Somalia, and Uganda, Kenya, and India subcontinent, and also in Brazil. In these three foci, the incidence is more than 1,000 cases per year. It goes to up to 30,000 per year as in Eastern Africa. This is Southeast Asia. At the moment, they have only 15,000 cases per year, and this is because of when they adopted the Ambisome single dose. And this is Eastern Africa. Unfortunately, it has a huge burden, while 30 to 40,000 cases. Unfortunately, the burden is mainly on Sudan and South Sudan. Kenya and Uganda, they don't bear the brunt of the high load of cases. In Brazil, they have like 3,500 cases per year. It's not that very high numbers, but complicated by HIV because HIV goes in the cities or actually goes to the countryside. So if you look to leishmaniasis all types, you see the map, even in the US, there is some cases of cutaneous leishmaniasis. And you can see Africa, the whole of Africa is endemic for, I mean, large part of Africa, Saudi Arabia and South Europe, the India subcontinent and part of the Soviet and so on. Spain, France, Italy, Mexico. So it is really a global burden. And it is endemic in 88 countries. That is to say, 10% of the world population. And visceral leishmaniasis among the top 10 entities in the world. More than 1.2 billion people considered at risk, 0.5 to 1 million new cases per year. This is all types of leishmaniasis, and 12 million people infected each year. From out of them, 50,000 cases die annually. And the burden is also depicted by that the DALI is 2 million 300 and like 60,000. This is the disability adjusted life years. Unfortunately, the re-emergence of Leishmania HIV infection also complicated the picture, and malnutrition, poverty, and migration and environmental factors, all these things work together, making visceral leishmaniasis or leishmaniasis is a disease or a group of diseases of high burden. And this is cutaneous lesion. And here is the mucosal lesion. And here is a Sudanese child that we took the photo, a Sudanese child with hepatosplenomegaly and a little weight loss. You see, the face is not looking as if he is having weight loss because in this case, usually people in the endemic area, they call visceral leishmaniasis. In Arabic, they call it a semih because the face is not affected. Usually the weight loss is from the arms and the chest and other muscles, but the face is always looks very well unless it is in its last days. So visceral leishmaniasis, as I mentioned, is a disease of children in the endemic areas, and you can see here this chart bar chart telling you that from 0 to 5 years, the children are Leishmaniasis skin test negative, like more than 90% are Leishmaniasis skin test negative. And Leishmaniasis skin test negativity, meaning that they are more susceptible to develop the disease. And when you go down, and by the age of 15 years, almost more than 40% are protected. Whereas when you come to 20 years, then 78 or 75% are protected. So protection from visceral leishmaniasis decreases with age. And until we reach, for example, the age of 36 to 40, the affected population or susceptible population will be less than 10%, whereas the protected people are more than 90%. And this because when you are in the endemic area, either you develop subclinical infection and then you become immune for life, or you had the visceral leishmaniasis or whatever type of a disease, and then treat it and you will be immune for life. And we benefited so much from this information for vaccine development. So the natural infection, whether subclinical or treated, offer the individual lifelong immunity. So if we simulate the natural infection by having a vaccine like a whole parasite vaccine, then we can cut the long story short because positive leishmaniasis skin test is a protective surrogate marker of the disease, from the disease. So you can see here that the picture, most of on your right hand side, the picture is showing you that mostly children, and that white man is Professor Ed. We worked with him for 20 years in the endemic areas here. So male children, few are adults. Maybe some adults here are healthy, but uh, they are just supporting their children so that they should not be afraid of having photos or so, because the people, they are very naive and they like photos, but sometimes they're afraid of it, of taking photos. So, is it easy to control leishmaniasis? It is very complicated, by the way, because if we consider active case detection, we have no RDT available to detect parasites. The RDTs that we have, they only detect antigens or antibodies or antigens, but they don't detect life or the whole parasite. Do we have effective treatment? The current treatments are toxic, like Ventustan, or expensive, like Ambizone, and logistically difficult because most of them are, or actually they are injectable, and sometimes for ambisome you need to filter the ambisome and you put it in uh, uh, infuse it in D5 or sodium glucose 5%, and you should not infuse it with normal saline because there will be some electrolyte problems and the ambisome may precipitate. So let's go to the control of zoonotic reservoir. Not all zoonotic reservoir are identified. And now we're doing eco-epidemiology of leishmaniasis, a big project started 3 years ago. And we're still working in collaboration with Ohio State University School of Medicine and also with our colleagues here from Kenya and Ethiopia. The aim of this study is to identify zoonotic reservoirs and also to identify the areas where the biting takes place, whether it is indoors or outdoors. Our colleague, Professor Naim, has done a great job in this. We are just complementing what he did in the past. So for vector control, resistance to pesticides is on increase. And not only that, but the endemic area is very large and the indoors or outdoors biting areas is not yet identified. For education and communication, we lack resources. We don't have good health system. So the communication is always lacking, especially the education. We used to do some education, but is not, we cannot sustain that because we usually ups and downs. Unfortunately, no vaccine is available against leishmaniasis for humans so far. There are so many molecules tried, but unfortunately, till now, no vaccine is available. So, because of the East Africa, uh, the disease is more or less the same in the different countries in Eastern Africa. We sat down in 2003 in Khartoum at the Institute of Endemic Diseases, and we developed the Leishmaniasis East Africa platform. And from this Leishmaniasis East Africa platform is composed of medical doctors, scientists, and by medical doctors I mean clinicians, immunologists, pathologists, and also entomologists, and also we group epidemiologists. So a big group, or like more than 50 people in the Leishmaniasis East Africa platform to control leishmaniasis under the support and the auspices of the Drugs for Neglected Disease Initiative, which is based in Geneva, and it is an non-for-profit organization and has been helping us till now since 2004. And because of this funding, we managed to establish some centers. For example, in Sudan, we have Al Hassan Center, Professor Ahmed Muhammad Al Hassan, the father of leishmaniasis and pathology in Africa, is known beyond the country and the continent. And also, we built Al Khair Center far in the endemic area. And in Ethiopia, we built two centers, Gondar Hospital, Gondar University, Ethiopia, and in Arba Minch Hospital, Addis Ababa University, Ethiopia. And in Uganda, we built Amudat Hospital in Makariri University, Uganda. And for Kenya, we built two centers, Center for Clinical Research, CCR, in Kemri, Kenya Medical Research Institute, and in Kemelel Center in northern Kenya, in the district called Baringo District. And I was lucky to chair this Leishmaniasis East Africa platform from 2007 up to 2014, and I managed to establish the Amudat Hospital, and I went there and I was selected as advisor for the Ministry of Health of Uganda since that time till now. So, so when we sat down, we first said, what new tools we need? We have to identify the new health tools for visceral leishmaniasis. And that paper was written by Asrat Hailo as the first source. Asrat is from Ethiopia, and myself representing the Institute of Diseases, Catherine Royce representing Drugs for Neglected Diseases Initiative, and Monique Wasona from Kenya office. So in the immunopathology, Visceral leishmaniasis or leishmaniasis in general is a disease of the immune system, or you can say immune-mediated disease. Usually the infection takes place in the macrophages. So the infection is in the macrophages, and because of this infection, the naive T cells differentiate into dominant Th2 response, which is characterized by the secretion of IL-4, IL-5, IL-6, IL-10, and IL-13. And these are pathogenetic immune response. That is to say, it propagates the multiplication of the parasite. So IL-10, what does it do? IL-10 inhibits interferon gamma and antagonizes its effect on the macrophages because interferon gamma is a Th1 response cytokine, and Th1 cytokine, which is known to produce, to propagate T helper cell 1, and that class of cells are protective against the disease. So it down regulates antigen presentation, which is a function of the macrophages. And it down regulates metabolic events associated with macrophage activation, whereas IL-4 and IL-5 are involved in B cell stimulation and humoral immunity. And therefore, there will be production of high levels of immunoglobulin G and immunoglobulin M, which are of no value in clearing the parasites, because these are the markers of humoral immunity. And we know that T cell cell-mediated immunity is protective, dichotomous of the protection against visceral leishmaniasis. So the clinical manifestations of visceral leishmaniasis, let us have an immunological view. We can explain all the symptoms and signs of visceral leishmaniasis by the immune responses. For example, fever, which is prolonged, is driven by pyrogenic cytokines, such as interleukin-1, interleukin-2, although they are not specific, but usually they come with acute infection and they continue, and also TNF-alpha acting on the hypothalamus. The weight loss and cachexia are linked to TNF-alpha and IL-6 driven metabolism. And fatigue reflects chronic inflammation plus anemia. Splenomegaly results from persistent antigenic stimulation with macrophages and lymphocyte accumulation, and also hyperplasia of the splenic cells. The tissue of the spleen undergoes hyperplastic multiplication and then causing a large spleen. Pancytopenia is mainly due to hypersplenism and maybe also due to splenic sequestration. In the classical teaching, we used to be taught that pancytopenia is due to bone marrow suppression. But we did many cases together with Professor Hassan, bone marrow aspiration, and we found that the bone marrow is active. And he mentioned to me that that he will give me 1,000 US dollars if you come with the bone marrow which is depressed in visceral leishmaniasis. So visceral leishmaniasis does not cause bone marrow depression, but in many books, in many articles, they usually say bone marrow depression, but we did not find any bone marrow which is depressed. The bone marrow is hypercellular, compensating the destruction of the cellular elements outside the bone marrow. So anemia relates to IL-6 hepcidin effects and also splenism and splenic sequestration. And IL-6 is very important. It is linked to hepcidin, which usually contain the iron. And when hepcidin, IL-6 hepcidin interaction takes place, then most of the iron will be stored in the macrophages or in the hepatocytes, and then there will be no high load of iron in the serum. So usually the patients develop anemia. Leukopenia and thrombocytopenia result from a splenic sequestration as well, and bleeding tendency follows low platelets and coagulation abnormalities, and also there's some sort of vasculitis, especially in epistaxis. Hypergammaglobulinemia reflects chronic B cell activation. As we mentioned that they produce immunoglobulin G, IgG, and IgM, but they are not effective in clearing the parasite. Secondary bacterial infections occur due to impaired cell-mediated immunity. So usually some patients come with tinea versicolor and fungal infection, but also they come with pneumonia and other infections, skin infections. Sometimes pneumonia can be very severe to the extent that is the leading cause of death in children with visceral leishmaniasis. So there are atypical presentation of visceral leishmaniasis like in the intestine. Usually in the intestine, the Leishmania enteritis is caused due to parasitized macrophages in the lamina propria in the small and large intestine, leading to diarrhea. And sometimes ulceration and bleeding may occur. Fortunately, these changes are reversible with treatment. In the lungs, pulmonary bleeding is a constant finding in patients dying of visceral leishmaniasis because they develop interstitial pneumonitis. And bleeding may be from other part of the mucosal lining in the GIT, the nose, the retina, and the brain. In the kidney, the glomerular changes related to immune complex deposition, like the membranous, GN, and mesangial thickening associated with nephrotic syndrome. So visceral leishmaniasis can present with nephrotic syndrome. Unfortunately, nephrotic syndrome due to visceral leishmaniasis is reversible. Interstitial nephritis with presence of parasite leading to impairment of renal function. This is why we are very careful when infusing or when injecting patients with promomycin. We have to make sure that he has no or she has no renal impairment before embarking into medications. And as I mentioned, that all these changes are reversible with treatment. In the eye, patients develop bacterial uveitis, and in this case, you have to give steroid eye drop together with the anti-leishmanial medications. So we have published blindness in the endemic area, basically due to anterior uveitis, due to visceral leishmaniasis, because they cause both colors are ocular leishmaniasis. Usually the disease is mainly on the eye, so they develop blindness. We published in the Tropical Doctor, I think so many years ago, like 10 years back or more, we published a paper about the blindness in the endemic area of children, and there is mainly temporal relationship between development of visceral leishmaniasis and treatment, and development of PKDL and post-Salazar ocular leishmaniasis alone or together with PKDL. They also present with leishmanial conjunctivitis, and you can see here this is the eye of a 15-year-old patient, and we have isolated the parasite uh, the uh, from the iris, and this is the lower down photo is by electron microscopy, and you can see the rounded on your upper left corner of the uh, photo. You will see some parasites there, and also this is conjunctivitis, very severe, sometimes leads to disability. Also, the nervous system is affected. This was reported by Professor Dawood Mustafa, Professor Ammar Tahir. They reported peripheral neuropathies, and we reported cerebellar ataxia from the Tropical Disease Hospital, together with Dr. Muna Hussain. And also, the cranial nerves are affected, the cerebrum, nerve deafness, frank psychosis, and also we found evidence of demyelination and axonal degeneration. So visceral leishmaniasis is not just a disease that can be treated by a medical assistant. So as most of the people, they say that it is an easy disease and you can just diagnose and give the medications, but you need to follow your patient in hospital because he might or she might develop one of these complications during before treatment or during treatment and even after treatment. There are some comorbidities like infections like pulmonary TB, usually complicate visceral leishmaniasis, hepatitis B and C in 8% of cases, usually herpes simplex and zoster. There are few, but they usually present in visceral leishmaniasis. Children usually develop otitis media, and as I mentioned, bacterial pneumonia, common in young children, and maybe the leading cause of death. Concurrent or is also in the malnourished children. And we have seen candida infections at teenage vesicular. And by the end of treatment, when you start your patient, he comes after 6 months without any candida infection or tinea versicolor because the immune system by 6 months usually recovers and the patient become immune against such infections. HIV/AIDS, few in Sudan, but up to 30%, 4% in Ethiopia. And VL in adults is considered as AIDS defining condition as mentioned, or you can see that in the WHO guidelines. So if you have an adult in the endemic area with visceral leishmaniasis, it is mandatory to test for HIV. So the laboratory presentation of VL, the Leishmanian skin test, usually non-reactive, and this is because of the Th2 response, because LST is the marker of Th1 response, which is a protective marker if it is positive. Also in the lab, you will find hypergammaglobulinemia by ELISA, for example, and this is also Th1, Th2 response, which is, as I mentioned, IL-4 and IL-5 responsible for stimulation of B cells to produce high loads of immunoglobulins. Also, we have high ESR up to 3 figures or more, and this is also due to hyperglobulinemia. Pancytopenia, as we mentioned, due to destruction and sequestration, hypoalbuminemia, which is a negative acute phase protein, elevated transaminases, hypercellular polymer. It is active. This I put two question marks because I found in a lot of papers in the literature they always said that there is bone marrow depression, but in Sudan we did not find a case of depressed bone marrow so far. Hyperbilirubinemia is not common, but if it's there, then we call it a grave sign, and usually patient cannot make it when they have hyperbilirubinemia. So how do we diagnose visceral leishmaniasis? Before we do that, you see from sandfly, usually the infection takes place in the macrophages, and then humoral immunity will develop. and then high antibody production will be featured, and then there will be resistance of antibodies after cure, and there is also difficulty to distinguish between active and previous infection. This is just to put you in the picture that following infection, usually humoral immunity supervene, and then antibody production will take place in large amounts. So the conventional methods are microscopy or culture and culture. By microscopy culture, we mean that we take tissue from the human, whether from the lymph node or the bone marrow or the spleen. Fortunately, we did not practice, I myself, I did not practice splenic puncture because when we came to Leishmaniasis research group based at the Institute of Endemic Diseases, we found that they have the splenic puncture is abundant because of the hazards of splenic rupture, especially when it is in the field. The problem of the microscopy is that there is lack of well-trained people to visualize the parasite, and also it is invasive, so it is careful. Uh, uh, I mean, carefully taking the aspirate from the lymph node or the bone marrow. And in the analysis of the data we have in Doka Center, we found that in 88% of cases, we can diagnose patient with visceral leishmaniasis based on lymph node aspiration. Although in the 90s, they say they said that they published that the sensitivity is up to 60%. But with training and experience, we have a very good technologist who has been working for the last 40 years in leishmaniasis, and he managed to score high mark when was assessed by Professor Tony Moody from England. He was given 45 slides and he scored all the 45 slides. He scored correct whether it has parasite or has no parasite. We are very proud of him in East Africa because other colleagues or his colleagues from Ethiopia and Kenya, they failed to attain even 80%. And he's now based in Khair. He is a microscopist. And also the culture is the problem, by the way, and it takes time, maybe 1 week or 2 weeks to have growth of the parasite, and usually contaminated because of the skin usually of the countryside people maybe is having a lot of infections and so on. So, so the microscopy and culture, although they are the gold standard, but unfortunately they are logistically difficult and they need good health system with regards to infrastructure in the lab or manpower. When we go to the molecular based, which is a PCR, it is highly sensitive, but it is very laborious and very sophisticated. Also, people are now trying to produce less laborious PCR methodologies, but we did not see that till now in Sudan. The serology, which is by serology, I mean the RDTs with the antibody detecting tests like RK39 and RK28, or antigen detecting tests like the CATEX. And I have to mention that care clues in infected B. orientalis with Leishmania by feeding them on Picoidal lesions. And this is very, very important. I tried this in two patients with Picoidal, but they have started the treatment, and I failed to grow together with an entomologist from the Faculty of Science, University of Khartoum, we failed to grow parasite in the stomach of the sandfly. So the comparison between the RK39 and RK28, because they are commonly used, the antigen of the RK39 is a kinesin repeats only, whereas RK28 is fusion protein, and there are fusion protein from RK26 and RK9. The components RK39 is basically one epitope, which is, one specific epitope, but repeated 39 times, which is 39 amino acid kinesin repeats. But in case of RK28, we have other molecules has one and has two together with the RK39 repeats, and this is to increase the antigenicity and the epitopes, so they have the multiple antigens, not like single antigen. So the antigen diversity, RK39 has single antigen repeated 39 times, but these are multiple antigens, so they provide large area, surface area for detection of the Leishmania antibodies. So the original aim of RK-Citran is to be universal VL diagnosis for that, but unfortunately it did not do well. There is a miss of 1 in 4 patients, um, uh, so the false negative is very high when using RK-Citran, especially in Eastern Africa. And this is why our group at the Institute of Endemic Diseases, led by Professor Mukhtar, improved East African diagnosis by developing RK28, and he tested RK28 in 285 individuals. Some are controls, some are patients, confirmed patients by lymph nodes or bone marrow, and improved East Africa diagnosis. But RK28 has a problem, and I will come in a minute to speak about. So the WHO recommended RK39 for to be the RDT of the most important one, but not currently recommended as a replacement. I mean, RK28 was not recommended so far by WHO to, to replace RK39, although in the guidelines of the Sudanese guidelines for treatment of this diagnosis of leishmaniasis, in the algorithm, RK28 is included. So the performance of RK39 is of lower sensitivity in East Africa, but RK28 similar or modestly improved, but inconsistent. And this is why WHO did not replace, because more or less the same, although in some cases in Sudan, exactly in Sudan, it is better than RK39, but it has a major drawback, which is discovered by the group of Said Safi in the Faculty of Medicine, University of Khartoum, and they told us that they published that RK28 has the ability to cross-react with Plasmodium homologous antigens or proteins. So these are the arguments against antibody detecting RDTs. The principal limitation of antibody-based diagnostic is that they detect an indirect marker of infection, which is a host immune response. So when you are measuring the antibody, that means you are measuring the immune response to the infection. And this is very, very variable. So it is not a direct marker of infection. The direct marker of infection is the presence of the parasite. But this is why we are against immune diagnosis, because of this variability. Because the immune response is different from one individual to another. It's different from HIV, VL co-infection, and primary VL.
is different from pregnant ladies to boys and so on. Malnutrition, there's so many differences. It's very variable, the immune response. So we cannot depend on the antibody-based diagnostic. And this is the principal limitation, as I mentioned. Consequently, the future of VL diagnosis is likely to rely increasingly on antigen detection assays and molecular diagnostic rather than further refinements of antibody-based tests. So this is a very important point here. So the goal now is towards antigen detection and molecular diagnostics rather than refining the antibody-based test, although there are some studies now going on trying to improve the capacity of capturing the capacity of RK39 to capture more antibodies or lower level of antibodies. Because this response varies across individuals and populations, no single serological test is likely to achieve uniformly high accuracy worldwide. This biological variability underpins the growing interest in direct parasite detection through antigen-based and molecular diagnostics. Although RK28 performed better than RK39, but not uniformly consistent, is not consistent. RK28 limitation is the cross-reactivity with plasmodium homologous antigen. Therefore, the WHO did not replace RK38 with RK28. So I hope that these arguments are clear. So we believe in RK28, we believe in RK39, but there are some limitations. So if we are going to improve them, then for RK38, we have to expand the antigenicity or the epitopes or the areas for the detection, the epitope for detection of the antibodies. For RK28, the problem is that usually in East Africa, visceral leishmaniasis is co-endemic with malaria. And this is a problem, so that this will increase the false positive and treating patients who are not visceral leishmaniasis cases unnecessarily. So the antigen detecting test, no progress so far. It measures active infection. People are now revisiting the catex, which is the urine antigen, and it is a potential for monitoring cure. Yes, but it has problems with immune complexes and renal filtration because usually they use it in the urine. Even if they use it in the serum, but also immune complexes may not, may interact with the detection of the Leishmania antigens. So, although in visceral leishmaniasis, during infection, we have very high load of antigens in the serum, but unfortunately, when they come to be filtered, they become like an immune complexes and larger molecules, and very difficult to filter them and to appear in the urine. This is why the urine test, which is Kala-Azar text, Catex, is not working or did not give promising responses, especially in HIV patients whom we expect to have high loads of antigens. So what next? What is next? Next, I think we are now embarking into a new generation of RDT. We call it next generation RDT. And now we are developing a protocol. The next generation is now undergoing some final assays in vitro. And we have written the protocol together with our colleagues from Japan and our colleagues from Ohio State University to develop next generation RDT, which is usually uses 450 nm platinum embedded latex. Platinum embedded latex nanoparticles using RK39 platform. So we are not using RK28 because of the problem of the homologous antigens with malaria, but we are now trying to increase the surface area of the RK38 39 so that can detect as much as lower antibodies. It provides a surface area 9 times larger than conventional 50 nm gold colloids. So RK39, we call it conventional, and usually it has like 50 nm uh, gold colloids, which is not that sufficient to detect all the antibodies. So the antibodies that with low threshold, patients with low threshold antibodies, they usually test negative when using the conventional method, which is RDT, RK39. And this increases the false negative and missing a lot of patients. But using 450 nm platinum embedded latex, we will be increasing the capacity of RK39 to capture like 100 times or 100 folds of the antibodies. The performance will be 100 folds of the RK39. And this is will be very important for Sudanese people because in 2008 there was a report by Professor Mukhtar and his group and from the institute and other from Ethiopia, Kenya, and they published a paper and they made it very clear that the Sudanese patient with this leishmaniasis produce low titers of antibodies. And this is why the antibody detecting tests are not suitable for Sudanese patients with small NM, uh, like 50 NM gold colloid. So we are increasing this. So it allows the RDT to capture trace amounts of VL antibodies, demonstrating up to 100-fold higher sensitivity than commercially available tests like RK39. Its platform employs proprietary 450 nm platinum embedded latex nanoparticles. Because surface area scales with the square of the particle radius, over 450 nm nanoparticles provide approximately 81 times the surface area of the standard 50 nm gold particles. You see, this is 9 times, but it is 81 times the surface area. So the preliminary proof of concept, POC, testing using VL-infected mouse plasma has successfully demonstrated that this platform achieves a limit of detection up to 100-fold more sensitive than leading commercial RK39 RDTs. And we are expecting to start the study next year in April, and it will take 2 years to have the results out. And if it is successful, then it's going to be like an addition to the rapid diagnostic test or even a useful rapid diagnostic test for visceral leishmaniasis. So, are you following me?
We are.
Hello?
Yes.
Good.
Very, very
Good.
interesting talk. Thank you so much.
Very good. Thank you. So regarding the drug development for leishmaniasis, the story is that we did not have new chemical entity. So we kept repurposing and combining the available drugs, and we call them the orphan medications, like pentastam, sodium stibogluconate, and bromomycin. And bromomycin is an aminocidine, aminoglycoside, and it was discovered in the late 60s, in 1960s, and was used as an antibacterial medication. But in the labs, we found that it has an Leishmania parasite effects. So it affects the cell membrane, disrupting the cell membrane, so causes parasite deaths. So why there is a need for new medications? And as I mentioned, the available treatments are far from satisfactory. They're either toxic, expensive, and also resistance is on increase, especially in Sudan because of the haphazard use of the medication. Sometimes patients do not use the medication in hospital, so some cyclists they move around like health workers. They move around and around, and they have fake medications, and they inject the individuals in sub doses, and then with time, I think we'll lose the drug of great majesty and like pentastam. Fortunately, we're pushing very hard to put the sodium stipogluconate on the shelf because we are looking to the, although children are morely affected, but there are other people who can visit, for example, the endemic area for other businesses and might contract the disease, and mostly diabetics or hypertensives from outside the endemic areas. So in that case, SSG will be contraindicated. And logistically, it's very difficult, like the storage and the administration, like Ambizome. We have lost a lot of vials. I mean, like hundreds and hundreds of vials when some of the medical officers stored Ambizome in the fridge, in the freezer. And then if you put it in the freezer, then you have lost this medication because there will be separation between the liposome lipids and globules and the amphotericin B, which is very toxic. So I think one of the incidents that I witnessed in rural hospital there in Eastern Sudan, some cases they started to develop renal failure because of using this ambisome after it was recovered from the freezer. Fortunately, amphotericin B side effects like renal injury is reversible. And when we discovered that, we stopped. We instructed to stop and also to destroy all the medications. The WHO is pushing very hard for combined therapies. It's like HIV, TB, malaria, all these infectious diseases. I mean, to prevent resistance and shorten treatment duration, this is why WHO is pushing hard for combined therapy. What is the challenge to develop new medication? The challenge is that developing new chemical entity takes decades because sometimes it takes 15 years to develop a new medication because you need to go through a lot of, I mean, stringent testing, preclinical, in vitro selection of plants or whatever, and then you do in vitro testing, and then in animals, and then you go for human health individuals, phase one, and then you go for phase one in patients, and phase two in patients, and then phase three. This takes like 15 years at least. This is a major challenge, but we have something in our hands at the present time. So the story is that when we started developing rapamycin and SSG, which is the treatment, the first line treatment nowadays in Sudan, we started using the Indian dose, which is 15 milligram for 21 days. But unfortunately, this 15 milligram for 21 days did not work very well in Sudan. So we stopped the study and we conducted another study and compared between 15 milligrams for 28 days, increasing it by one week. That is increasing the dose, the total dose by 33%, or the other arm is 50 to 20 milligrams per kilogram per day of rapamycin for 20 days. So increase the daily dose by 33%, or increase the total dose, I mean the length of the duration, to 28 days. In the two cases, they receive two arms, they receive the same total dose, but different durations. Because we are looking for shorter duration, we this is what we developed: Promethazine for the treatment of visceral leishmaniasis in Sudan, randomized open-label dose finding study, and we managed to find a good dose, which is 20 milligrams per kilogram per weight for 20 days. And and this was combined with SSG in the next step. So promomycin for 20 days, 20 milligrams, the efficacy was 81%. In fact, when you come to a combined medication, there is no need to have more than 90% efficacy of either medication. You need to have both of them have efficacy of more than 70%. This is why when we started using the same dose of Indian subcontinent, we attained like 64% or so efficacy. So we stopped the study because we cannot combine SSG with this efficacy, combine promycin with this efficacy with SSG. Then we did this dose finding study in 40 patients. 20 patients received 15 milligram for 28 days, and the other group received 20 milligram for 20 days, for 21 days, and we managed to have 81%. Then we moved to phase 3, which is now, after finishing this promycin development for the treatment of visceral leishmaniasis, the dose finding, then we started again from the beginning to develop sodium stipogluconate and promomycin combination compared to SSG for visceral leishmaniasis in Eastern Africa, randomized control trials. And these two studies were led by me. As you can see here, the 17-day SSG and VM combination treatment had a good safety profile and was similar in efficacy to the standard 30-day SSG treatment, suggesting suitability for VL treatment in East Africa. Now it is the first line treatment in East Africa, and that was since 2012. So we looked for other alternative treatment regimens because we have done this economic burden of visceral leishmaniasis study. And the first was here is Philip. He is from Morocco. He's from Belgium, and he's a collaborator with us. And he's economist, and we help him to develop a model of calculating the cost of treatment, not only the cost of the treatment, but also the fixed cost of the hospital, the beds and the nurses and all these costs. That is to say, trying to see whether reducing the duration of treatment is going to help or not. And because of this, we moved to another clinical trial to develop new medication or alternative medications. But before we go to that, we have done a pharmacovigilance study in which we managed to tell the people that SSGBM was effective and safe, except in HIV/VL co-infected or older patients, because older patients usually are susceptible to cardiotoxicity when using sodium stipogluconate. So although we have 17-day course of SSGPM, at that time we are very happy with that, although they are not ideal, but that's what we had at that time. But we continued looking for alternative medication. Then we conducted a study again on symptomatic patients with parasitology confirmed non-severe VL. This is a single dose of ambisome of 7.5 milligrams body weight on multiple doses or multiple doses 7 times, like 3 milligrams, and in total 21 milligrams. But unfortunately, it did not work. It did not attain 90%. We conducted this study because Shyam Sundar from India developed a medication using ambisome single shot of 5 milligrams. So when we started to discuss why, whether we use the same dose or not, we had a consensus that East Africa visceral leishmaniasis is very tough and very severe compared with Indian subcontinent visceral leishmaniasis. This is why we started with 7.5 milligrams. But unfortunately, it did not work. And this is also our group here. It did not work. The ambisome 7.5 milligrams or even multiple doses did not attain 90% efficacy, because if it is not 90% efficacy or the margin is not that big, large, like 2 or 3%, then we can accept it. We cannot accept it based on the WHO recommendation that treatment of visceral leishmaniasis, I mean, the medication should be efficacious above 90 or above. So we abandoned that and we moved for another medication, trying to include ambisome plus multifocine, comparing ambisome plus SSG against ambisome plus multifocine and multifocine alone as a third arm. And you know, multifocine is anti-cancer medication, but it has anti-Leishmanian medication. But unfortunately, at day 220, which is a 6 months follow-up, this is the final definitive cure. We managed to find that ambisome plus SSG attained 87%, whereas ambisome plus multifocine is 77%. Multifocine alone is 72%. So with lower efficacy in younger children who have low weight. So multifocine pharmacokinetic data indicated underexposure in children compared to adults. So I managed to also supervise one of my students to see whether whether we can increase 7.5 milligrams of ambisome to 10 milligrams. But unfortunately, when we took the serum samples of those guys who received the 7.5 milligrams, we found that there are some markers of complement activation pseudo-allergy. He did his master's degree, and we concluded that we could not increase the ambisome as a single shot above 7.5 milligram. Otherwise, if you go for 10, then you might develop complement activation pseudo-allergy, which is called CARBA, which is very difficult and may kill your patient. This is the efficacy and safety of ambisome in combination with sodium stipoglycinate. This is also our group led by Dr. Monique Wasona from Kenya. So now we fed up with all these things and we moved to multifocine and promomycin clinical trial. And we designed an open label phase 3 randomized controlled multicenter non-inferiority trial to compare efficacy and safety of multifocine and promomycin with SSG and BM combination for the treatment of primary visceral leishmaniasis patients in Eastern Africa. And the primary objective is to compare the efficacy of two combination regimens of promomycin 14 days and miltefosine 14 or 28 days. So we have two arms, promomycin plus miltefosine for 14 days and promomycin 14 days and miltefosine for 28 days. So, and then compared with the standard of care, which is the 17-day course of SSGBM in the treatment of patients in Eastern Africa. The secondary objective is to see the pharmacokinetics and the pharmacodynamics, and we did all these things, and we moved on, and we managed to conclude that bromomycin and multiplicin combination is efficacious and also safe and friendly. This is a paper published in Clinical Infectious Diseases in 2023. And the conclusion is that the efficacies of BM and MF, multiplicin, and SSGBM were similar, and the ADRs were as expected given the safety profiles of the drugs, with one less injection each day, because this is 14-day course. I mean BMF 14-day course. So we have spared 3 days of treatment. We have reduced the treatment by, I think, 18% or something like that. And also we have reduced the injections to 1 injection, because SSGBM are 2 injections. But in multiplicin, BM is only 1 injection, and multiplicin is an oral medication. And with one less injection each day, a reduced treatment duration to 14 days, and no risk of SSG-associated life-threatening cardiotoxicity, BMMF is a more patient-friendly alternative for children and adults with primary VL in Eastern Africa. But we know that multiplicin is organic. This is why we did not recruit patients, especially females of childbearing age. So we excluded them when they are 12 years or 11 years and above. And this can be also a problem, but because countryside are children, the patient are mainly children, like 80% of the individuals are of the patient are children, then this medication was accepted. The combination was accepted by the WHO, and it is in the guidelines. And we have also submitted the clinical study report already, submitted to the Ministry of Health in Sudan in 2022. And we are still waiting for the approval to be included in the guidelines. The first line treatment together with SSG, PM, also as the first line treatment. So now we are providing patients with combination of MF, BM, and this is, we call it a new strategy, and it treats BM-MF combination therapy could be an alternative to SSGBM, minimizing the number of injections and removing antimony-related toxicity, a reduction of peak-adrenal incidence. It could be an attractive option for children who represent a high proportion of the population at risk, and the elderly who are most at risk of SSG-induced toxicity. The inclusion of BM-MF as a standard of care treatment of patients with primary VL in East Africa is a suitable new strategy, and we have to have the harmonization between the 4 or 5 countries in Eastern Africa to use this medication in the guide, to put it in the guidelines, to insert it, to include in the guidelines of our countries. And I have also this slide, I presented this in by Zoom meeting. This is one of the slides I presented on this study. So what's next? Still, we're not happy, although we made a progress from 30 days to 17 days, removing SSG cardiotoxicity, and now we have BM multiplicin. Multiplicin is teratogenic and causes gastrointestinal upsets. but we need to have something that we can treat all patients. So this is a new chemical entity. We were planning to start this in Sudan, but unfortunately, because of the war, the study now is ongoing in Ethiopia, which is called LXE 408, and it is developed by DNDi and Novartis. This is a potential oral treatment, and it is a first-in-class compound was discovered at Novartis. It is a proteasome inhibitor, proteasome of the parasite inhibitor. This is its action, and it was funded by Wellcome Trust in the UK and the European and developing countries clinical trials based in Germany. And its action, it targets the proteasome of the parasite, whether elephantum or L. donovani. And in phase 1 in Brazil and India, they gave promising results, but not yet out. Based on the clinical study report, the study started as phase 2 in Ethiopia in comparing 14-day oral XE408 with the standard of care, which is a 17-day course of SSG-BM. And I think the study about, to be out, the recruitment and follow-up are complete. The results are expected to be by or during 2026, maybe in the coming few months. We'll have the meeting to see the results. And Sudan will be also part of phase 3 clinical trial in the future if phase 2 gave good results. So it's being co-developed by DNDi and Novartis and is effective, could offer a simpler, needle-free regimen compared to the current injectable regimens, which is BM, SSG, or BM multifocin. So there are other new chemical entities, but for example, DNDi also developed the 6899, which is in phase 1 safety and pharmacokinetic studies, still in the laboratories there. And also the DNDi 6174 is planned for first in human, phase 1, in human, phase 1 starting in 2027. Other candidates like DNDi 0690 and GSK 245 were stopped. I don't know why, but it's maybe confidential, and we will see that later. DNDi 6148 is on hold, definitely is going to resume. So I can tell you that we have some new chemical entities, and we will be also trying to fix as many as we can, like 2 drugs or 3 drugs in one tablet, like Quartum, which is a combination of 2 medications. So I'd like to take the advantage of fixed combination therapies for visceral leishmaniasis. And by the way, me and Dr. Prema are working as consultants for drug development for Novartis. And recently we had a meeting in Uganda for pediatric formulation. So this is for recommendation in the guidelines. So multifocin plus bromomycin combination for either VL finished and now waiting for inclusion in the guidelines. Picadale for also bromomycin and SSG for Picadale, also conducted by Dr. Prema Musa. My colleague is the Institute of Endemic Diseases, are also finished, and we are waiting for including them in the guidelines. And in Ethiopia, VL HIV care optimization also finished using multifocin plus bromomycin. So what's next? Again, pediatric formulations. We feel that we have to have specific clinical trials for children, because children major proportion of VL cases, and this is the interest of Novartis and DNDi, and we need to develop child-friendly oral formulations and better be in tablets because we should not have it suspensions or syrup because we may need also some storage areas, refrigerating and so on. But tablets can withstand temperature very well. And also using weight-based dosing, not allometric dosing, because in multifocine we use allometric dosing, not only the weight, but the size, the surface area of the individual. And these are the future priorities to develop pediatric formulations. So these pictures you can see in your upper right uh, hand side, you have two centers. The one in the corner, this is the Umm Khair Center, a two-story building. And now we have a team there. And this is in Doka, Professor Hassan Center for Tropical Diseases. And this is Professor Hassan when we have inaugurated, when we inaugurated the center. And this is me here with the community leader, with some photographers, a cameraman. These are the lab technologies in the laboratory. This is in Doka Center, by the way. You can see this is a very clean and very neat lecture theater in the Doka Center. And you can see here I'm delivering a talk and together with my senior staff like Professor Hassan, Professor Khalil, and other people. This is what we have achieved. We have new treatments, and we want to include them in the manual for the diagnosis and treatment of leishmaniasis. We have good infrastructure in the endemic area, in the heart of the endemic area, so the access for therapy or for studies is easy. And we have also good manpower. We have many medical doctors and many technologists and even nurses, not only for routine care, but for conducting clinical trials, whether drug development, vaccine development, or diagnostic evaluations. So now we move to the vaccine development. So um, the story is like that. The first generation vaccine, which was, tried long time ago in 2000s from, the paper published in 2000, which is the CD4 epitope based and was manufactured by Razi Institute in Iran, which is a WHO center. It's called autoclaved Leishmania major, which is ALM plus BCG. It was not efficacious. But the most important information that those who converted in the Leishmanian skin test, they are better protected from developing the disease. So then we moved to alum precipitated ALM plus BCG, that is to say, we have adjuvanted the the ALM plus BCG, and alum is aluminum hydroxide. And this gave a promising result in phase 2, and we have conducted 2 clinical trials. But WHO recommended stopping this vaccine, the vaccine development, due to the lack of standardization, and it is a crude vaccine. Maybe because they're looking for other high-tech vaccine at that time, because Steve Reed and his group are producing a lot of high-tech vaccine. So, but this vaccine, alum precipitated ALM plus BCG vaccine, gave promising result in immunochemotherapy for PKDL. And that's what I did my PhD in immunochemotherapy for vascular leishmaniasis using alum plus BCG and sodium stibogluconate. And also in CLL in Mercado Benta in Latin America, also he managed to treat cutaneous leishmaniasis. So close the chapter of the first generation vaccine, the killed vaccine, and we move to the second generation vaccine, which is a recombinant antigen Lish trifusion plus MPL plus SE, and that was manufactured by IDRI, Steve Reed Group in Seattle in the USA. but it did not give any promise in prevention and therapy, whether in Sudan or in India. And then we move to the third generation, which is a vectored vaccine. And this is better than the previous ones because it has two epitopes, more epitopes like CD8 and CD4 epitope based. And that was funded by Wellcome Trust and University of York, United Kingdom for therapy and prevention, which is from 2016 to 2029. We're still doing these studies. For the therapeutic vaccines, phase one in the UK was conducted a long time ago and published, and we have conducted here in phase 2A, in the IND, which is for therapy for PKDL, and gave promising response. And then we moved, this is single arm, but we moved to a comparative study 2B, which was finished, but it did not give good response. But we are now, we stopped these studies and we conducted a study looking for the immune status of individuals after treatment of visceral leishmaniasis, trying to inject the vaccine after treatment of visceral leishmaniasis to prevent development of post-Kala-Zarr leishmaniasis, which is like more than 30% of patients develop the post-Kala-Zarr leishmaniasis. And also would like to revisit why the vaccine did not work very well in phase 2B. I have a lot of, explanation for that, but the time is too short. To mention all these things, we had a big meeting, extensive discussion, and we should not kill the chimpanzee adenovirus 63 CAH vaccine, which is a vector vaccine. And we spend a lot of time and money together with the University of York and Wellcome Trust for developing this vaccine, and we should not kill it without having, good explanation. So, so now the other generation, you see, there are three generations. The genetically attenuated live parasites, the advantage over the other approaches. The live attenuated mimics natural course of infection. It provides complete array of antigens, controlled persistence without causing clinical disease because it is live attenuated, genetically defined mutations, well characterized. So live attenuated vaccine is known, and you can also see that smallpox, yellow fever, polio, MMR, and bacteria, typhoid, BCG, rheumatoid are safe and effective. These are not live attenuated vaccines, so we are trying to test the live attenuated vaccine. But how did the live vaccine manufacturers? How did they manufacture the vaccine? It was manufactured in the US, and in the 2024, I was in the US discussing the development of this vaccine, which is going to start this month in phase one in Brazil. And there's no way to have it in Sudan nowadays because of the problems of the political issues and so on. So it is centrin deficient. But what is centrin? Centrin is a calcium binding cytoskeleton protein found in all eukaryotes. And Leishmania parasite is an eukaryote. And it is expressed in mastocyst specifically and localized mainly to centrosomes of or basal bodies. And centrosomes is very important in cell division. So that means when we delete or knock out this centrin gene, then the centrome will be affected, and then there will be no cell division. So you give the organism no cell division, it is a whole parasite, so it's going to be internalized into the macrophages, because entry of the parasite in the macrophages is by two ways, either through by directly by the parasite or internalized with immunoglobulins into the macrophages. So we will be introducing the live attenuated parasite, which is not going to multiply in the macrophages, and then the macrophages will take the advantage of this infection and makes the Th1 response as if it is a subclinical infection, and then the individual will be immune for life unless he develops or she develops HIV or steroid using steroid therapy or cancer or some sort of immune depressing conditions. So live attenuated vaccine, how is it developed? The first thing, they tried it in L. donovani. L. donovani, negative, negative, minus, minus, that means centering gene, L. donovani, centering negative, negative, and negative, negative, the genes could not be advanced as a vaccine for humans. Why? Using live attenuated eldonovir as a vaccine in humans could raise theoretical safety concerns due to visceralizing potential of eldonovir. We don't know whether this, although it is not multiplying, but it might also, while staying in the macrophages, might also visceralize. And when visceralize, it might change the virulence factors and then potentially may cause visceral leishmaniasis. And this is just a theoretical safety concern, but it was tried, but nobody found that L. donovani can do. But it's better not to touch L. donovani because of the hazards of developing visceral leishmaniasis. Live attenuated parasites generated by homologous recombination contain antibiotic selection markers could pose safety concerns in humans because L. donovani, by this recombination, they have antibiotic selection markers. And this, if you can introduce this in the body, it might also cross-react with other antibodies, antibiotics, and may cause also resistance. Anyway, we are introducing something that is going to affect the human body with regard to this antibiotic resistance selection marker. Therefore, using a dermotropic live attenuated Leishmania vaccine, which is L major, dermotropic, that does not visceralize, is antibiotic marker free, can cross protect against other Leishmania species because L major is a wild parasite in which you have all the antigen representation of all Leishmania species. So, so can cover, can overcome such concerns. And I remember that when we started the vaccine studies, because we use L major, because of the observation that patients who had L major infection in the past, they are protected against L. donovani. Therefore, L major has a huge cross reactivity, and it can cross protect against other Leishmania species. Those scientists who developed this L major centering negative, they use CRISPR technology, which allows the development of deletion of centering gene without integration of antibiotic selection marker gene. And you have to know that CRISPR stands for clustered regularly interspaced short palindromic repeats. And those who are interested in the molecular biology, they can go and click on CRISPR technology, which is in visceral leishmaniasis is linked to Cas9 because Cas9 is also important in the immunology of visceral leishmaniasis. So a genetically modified antibiotic selection marker-free Leishmania major parasite was developed, which lacks centering gene using CRISPR technology, and now it is ready for phase 1 clinical trial in Brazil. So L major centrin negative vaccine, folk medicine to clinic. Why folk medicine clinic? Because L major was practiced, live L major was practiced in Uzbekistan and the Middle East. And they used to people to take the L major and inject it in the covered area of their children. But unfortunately, because of the HIV and the immune depression, you cannot inject people with such live parasite, which is very virulent. You may cause disease and so on, or ugly scars. So we are doing leishmanization, but with fine tuning using CRISPR technology. So how does it work? L major, the wild type, this is the wild type, induces kynurenine and indole 3-acetaldehyde synthesis, which increases the production of IL-10 and TGF-beta. That is to say, is suppression of protective Th1 immune response. This is the wild type. The wild type, when they infects you, the patient usually develop suppression of protective immune response because they increase the production of IL-10 and TGF-beta, which is transforming growth factor. But the major century negative vaccine usually inhibit causes inhibition of urine and indole and then development of protective Th1 immune response. Melatonin pathway, increasing melatonin production and induces production of IL-12 and TNF alpha, which are the stimulants of Th1 response. So this schematic representation telling us that L major centrin minus vaccine usually end up with development of protective Th1 immune response, and that's what we need for protection against visceral leishmaniasis. This is just to tell you that the immunogenicity and there is a high load of interferon gamma when using L major centrin positive. I have to go quickly. And you can see here in this pie chart in symptomatic VL, these are symptomatic VL, when in 10 or 11 patient, 11 individuals injected by LM century negative, immunized. One of them developed visceral leishmaniasis. That is to say, the efficacy will be like 90% in animal models. Whereas if they are not immunized and challenged by a Leishmania parasite, so 36% of the individuals who are not immunized developed the disease. So L major centrine vaccine has efficacy of more than 75% against canine VL in natural transmission settings. The WHO recommendation is that if we can have a vaccine of efficacy of 50%, we can eliminate leishmaniasis within few years. So in summary, genetically modified Leishmania parasite LM centrin negative vaccine is safe, immunogenic, and efficacious in preclinical animal models against natural sunfly-mediated infection of CL and VL. CN centrin negative vaccination is a safe alternative to leishmanization with no adverse effects. Achieve large-scale manufacturing of cyclic GMB LM centrin negative vaccine, and I know that the vaccine production is led by an Indian company, but is based in the US. The toxicology studies of the CGMB, LM, centrin, minus vaccine showed no adverse reactions and established development of Leishmaniasis skin test as a surrogate biomarker of immunogenicity. Also, Leishmaniasis skin test is very important because this is a test that we will using it to see whether the vaccine is working or not. The CGMP grade LM centrin minus vaccine is ready to be tested in phase 1 study for its safety and immunogenicity, or in HIM. Transcriptomic and metabolomic analysis of LM centrim negative infected immune cells using bioinformatics tools identify new drivers of mechanisms of protective immunity. So GMB scalable method for producing a well-characterized Leishmanian antigen is established already together with this vaccine. So at the present time, it is very difficult to conduct this clinical trial, phase 3 clinical trial for VL protection against, for VL protection using the vaccine will be very difficult to conduct it in Southeast Asia with current incidences. If you can see here, the number of cases is very low. In 2016, only 6,000 in India, and in Nepal is 200, Bangladesh 200. So we cannot conduct such a study. So the study will be conducted mainly in Eastern Africa, and I can tell you that Sudan is number one country that is going to host this study in phase 3. But we have to do also phase 1 and phase 2 before we embark into phase 3. So how can you determine the vaccine efficacy? Can Leishmaniasis skin test be used for a surrogate marker to determine vaccine efficacy and also support ongoing surveillance to monitor eldonovan transmission? Yes, I can say yes, because you have a lot of experience in that. Edward Lester, who worked in Sudan for almost 10 years, in 1994, he looked at population exposed to L major migrating from West to Eastern Africa and uh, development of VL, susceptible to develop VL. 3 years following migration, 0 out of 668 Leishmanian positive developed visceral Leishmaniasis versus 7 of 509 Leishmanian skin test negative developed VL. So I have never seen a case of visceral Leishmaniasis throughout my work in Leishmaniasis with positive Leishmanian skin test and developed visceral Leishmaniasis. Although the Indian guys, they said that they have 15% of cases, they have Leishmanian skin test positive and they had visceral Leishmaniasis. But in Sudan, none of the Leishmanian skin test positive developed visceral Leishmaniasis as far as I know, and this from 1994. And also Khalil in 2002 also looked at the population in Eastern Sudan over a 2 years period, and 0 out of 301 Leishmanian positive developed VL versus 62 of almost 1,000 Leishmanian negative developed visceral Leishmaniasis. In Bangladesh, study conducted in village, the district, over 2 years, one patient who is Leishmanian skin test positive developed visceral Leishmaniasis out of 476. So India subcontinent visceral Leishmaniasis is different from what we have here. This is why you find Leishmanian skin test positive and visceral Leishmaniasis at the same time in India subcontinent. So currently, no GMP grade well-characterized Leishmanian antigen is available, but the prototype is developed by HERA in the NIH in the US and approved by the FDA. And now we are not injecting it in the individual and to read it, but rather we have to take blood and to subject this blood to stimulation by the Leishmanian reagent. And then if the production is interferon gamma, then this is a marker of protection. there is a big debate about whether using Leishmaniasis skin test to include patients. When you inject Leishmaniasis to recruit patients, if it's negative, to recruit them for the clinical trial because we need naive individuals. We usually do skin tests in the beginning. If they are negative, then they are naive. But and every 6 months we come and see the response. Repeated injections with LST, Leishmaniasis skin test, reagent. It is also antigens, composed of antigens, which is Leishmania major. So can induce more immune response, as some people mentioned that. Although Iman Sati from our group mentions that 4 injections of the Leishmaniasis skin test did not affect the core cellular mediated immunity. But there is a big debate. This is why we are trying to move from Leishmaniasis skin test as an injectable in the volar aspect of the left arm, like MAN2 test. We are moving from this to have the blood from individuals and culture them, stimulate them with Leishmanian reagent. These are the Leishmanian reagent, lyophilized Leishmanian antigen product. These are the formulations that will be used soon in Sudan to take blood from individuals, healthy individuals, or treated VL or VL on treatment and see what the response is. So the key message is, out of all what we have said, is that the limitations of current tools, whether diagnostics or drugs or vaccines, explain the need for innovation. Recent advances in diagnostics and treatment show meaningful progress, and vaccine development represents the next major step towards sustainable control and elimination. It also provides opportunities to incorporate Sudan's specific experience and my own experience in research contributions, making the presentation particularly relevant for both national and international audiences. This is what I wanted to mention here. So low antibody titers are one of the main reasons while why antibody-based diagnostic tests perform less well in Sudan and other parts of East Africa than in the Indian subcontinent. This is an important topic for my presentation. It links pathophysiology with diagnostic performance. The future of VL diagnosis is unlikely to depend on incremental improvement to RK39 alone, while optimizing recombinant antigens remains important. Combining advances in antigen discovery, regional specific antigen design, multiplex testing, and direct parasite detection will probably be required to achieve universally accurate point of care test. So this is Al Hassan Center, Professor Ahmed Muhammad Al Hassan Center for Tropical Medicine in Doha. And those are the guys from whom we learned a lot. This is Professor Kadaro on your right side, right side, and this is me. And this is Professor Hassan, and this is Professor Khalil, and those who are sitting, this is Bernard Picol, the director of DNDI. This is Professor Sumaya, when she was the Minister of Higher Education and Scientific Research, and this is Monique Basuna, the head office, DNDI head office in Africa. Those guys contributed so much to my education and also to my position now. So the acknowledgement, I would like to acknowledge the Leishmaniasis Research Group, based at the Institute of Endemic Diseases, Drugs for Neglected Disease Initiative in Geneva, Drugs for Neglected Disease Initiative Africa Office, Tropical Disease Hospital in Umdurman, because I have done my PhD work in there, and I presented some of my PhD in this presentation. The Ministry of Health, Gaddafi State, they are always helping us, and patients and community leaders in the endemic areas in Sudan. And thank you for attention. And this is a typical village in the countryside in Eastern Sudan. Thank you for your attention and listening, and I will be happy to discuss whatever question. If I know, I can answer. If not, let us see what the correct answer is. Thank you very much.
Thank you so much, Professor Ahmed Mudawi. This is truly outstanding and very inspiring and challenging information. Allow me to thank you on the behalf of Tropical Diseases Hospital. And thank you so much for this presentation. We needed to know about the latest updates in the management. Your lifelong dedication to improve the lives of the patients, to advance the national and international knowledge about this disease. It's truly inspiring to all of the doctors, seniors and juniors, to continue, and it's part of our responsibility nationally and internationally to devote and to study more and know more. I can't find enough words to express my gratitude and appreciation. Thanks for all the participants. We'll open discussion. Allow me to welcome Prof. Ali Habbour. If you have any remarks, questions, comments, please.
آه السلام عليكم.
وعليكم السلام ورحمة الله.
عليكم السلام بروفيسور عبور.
السلام عليكم بروف، كيف الأحوال؟
الحمد لله الحمد لله، كيف انت؟ ان شاء الله كويس.
الله يسلمكم، الله يبارك. تحياتي لكم من مدني. والحقيقة يعني احنا يعني الواحد يشعر بفخر واعتزاز كده انه يعني هذا العمل الذي بدأوه أسلافنا من زمان على راسهم بروفيسور ساتي وبروفيسور أحمد محمد حسن رحمة الله عليهم، انه هذا العمل مستمر يعني ومتقدم، ودي الصدقة الجارية إن شاء الله لهم. الحقيقة أنا يعني يمتد شكري للأخ أحمد بالرغم من مسؤولياته الإدارية والأكاديمية، لكن إنه وجد الوقت عشان just to tell us what they are doing in the field of Leishmania. Leishmania has been يعني a very big problem for us in Jazeera, and I've been in Madani since 1990. We see a lot of cases of Leishmania coming from Eastern Sudan ومن Sinnar. The presentation is always late. One of the main problems the two problems which I face over the decades يعني هما the problem was the diagnosis, and the second problem is the treatment with toxicity of drugs. And most patients they do not wait all this long time, so they just discontinue the treatment and go. And the third problem واجهتنا الحقيقة over the years هي lack of drugs. يعني بتجي اوقات كده نحن بالرغم انه الدرج فيها توكسيك وكده وبتاع، لكن الفلو of drugs is not available, was not available all the time يعني. لكن احمد الان بروفيسور احمد now is giving us a hope. هنالك يعني امل بانه في safe combination بالنسبه للاطفال، shorter duration، والامل الاكبر هو في الاورال treatment for children. ودي انا افتكر دي very good news. والخبر الثاني هو developing of a vaccine، لانه الليشمانيا ظلت صديق لنا يعني منذ ان كنا طلابا في جامعة الخرطوم وقبلنا والى الان. فيعني أنا أجدد شكري للقائمين على هذا الأمر، وأجدد شكري للجروب بتاعت التروبيكال ومستشفى التروبيكال وكل الجروب الممتازة اللي بتخلينا دايما يعني inform of what's going on in tropical diseases and neglected diseases. فشكرا لكم وتحياتي لكم من الجزيرة، ونتمنى أن نرى الفاكسين والأورال drugs soon بإذن الله تعالى، وشكرا.
شكرا جزيلا بروفيسور علي حبور، والله نورت علينا يا أخي الجلسة، وإن شاء الله نتقابل قريب يعني إن شاء الله ونتعاون بإذن الله، لأنه الفترة اللي جاية حيكون فيها بيدياتريكس، شغل بيدياتريكس فورميوليشن كبير جدا جدا، وغالبا بنحتاج لخبرات كبيرة في البيدياتريكس إن شاء الله.
Thank you so much. Allow me to welcome Professor Saeed Ahmed Idris, who kindly presented the last lecture. If you have any remarks or comments, please.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
عليكم
جزاكم الله
السلام
خير،
بروف، كيف الحال؟
بارك الله فيكم. الشكر كبير جدا لأستاذنا بروف أحمد على هذا الكلام الممتع. يعني really it was amazing interesting. زي ما ذكر بروف حبود برضو it give us a big hope from the field. احنا we are facing the problem of visceral leishmaniasis هنا in Qadari because we are facing the patient and their problem. It's really a big problem. واحدة من الحاجات الأساسية بروف أحمد اللي هي الديلي اوف، زي ما ذكر بروف أبور، delay of diagnosis. I think it is واحدة من character of the fever. يعني the patient with severe leishmaniasis usually they can do their ordinary activities in the early days of the illness. يعني زي ما ممكن يكون عنده severe leishmaniasis الأسبوع الأول والأسبوع الثاني يكون حايم بها عادي، ما زي الأذر febrile illnesses like malaria, tonsillitis, UTI, even common cold. عشان كده usually they present late. والحاجات اللي ذكرها بروف أحمد موسى الليلة هي حاجات يعني واعدة إن شاء الله سبحانه وتعالى، هو بأنه ترى النور قريبا، يعني خاصة فيما يتعلق بالديوريشن اوف تريتمنت. نحن كل ما قللنا فترة الادميشن كل ما قللنا الكوست وكل ما قللنا السايد افكت اوف ميديكيشنز. وهو انه في الايام القادمه انه الحاجات دي ترى النور وتخش البروتوكولات الجديده في الجايد لاينز الجديده ان شاء الله. الحاجه اللي انا موندرنج يا بروف احمد اللي هي بالنسبه للكومباينيشن اوف بيرتوفيسين اند بارومايسين. as you said انه بارومايسين is adjuvant therapy. Also methotrexate it is, I think it is not a real treatment for visceral leishmaniasis. I am wondering يعني in spite of this fact they give a good outcome. Thank you very much.
Thank you very much بروفيسور سعيد على الكلام الكويس، وإن شاء الله ويهوب إنه الأمور تمشي كويس إن شاء الله. وطبعا anti germ line cells يعني it kills multiplying cells. فبالتالي هو كان زمان as an anti cancer therapy. بعدين كان زمان لما بدأ في الأول الناس كانوا يفتكروا إنه بيعمل male sterility، ولكن الميل sterility tested في إنديا وجدوا إنه الشورت كورسز up to 42 days ما بتعمل ميل sterility، لكن لما تستعمله لمدة سنوات تبقى في مشكلة بتاعت low sperm count. ودي كانت إشكالية، ودiscussed الموضوع ده before we start the clinical trial. فبقينا نحن خلاص عارفين إنه 14 day course is nothing، ما بتعمل حاجة. لكن طبعا الحاجة المهمة إنه هو تيراتوجينيك زي ما قلنا، إنه هو بيأثر على المالتيبلاينج سيلز، فبالتالي ممكن child bearing age women ممكن يتأثروا، أو حتى إذا كان الوحدة جاء بسبب ليشمانياسيس وهو هي ما بريجننت، الدكتور المفروض يعني يكلمها، يوريها إنه يعني after يعني 6 months at least حتى بعد ذاك تبدأ، أو 6 weeks حتى تبدأ بعد ذاك to plan for pregnancy، لأنه it stays in the body، الهاف لايف بتاعه كبيرة شوية. والحاجة الثانية يعني احنا targeting children ما بتكون عندهم مشكلة ب 14 day course وبتأثر عليهم. وهو صحيح طبعا ما دام هو انتي جيرم لاين سيلز، بالتالي بيشتغل في الإشمانيا، بيأثر عليها بنفس الماشينري اللي بيأثر عليها من ناحية المالتيبلاينج سيل for a short period of time. قد يكون برضه عنده بعض السايد افكتس لكن negligible يعني، إذا كان أثر على المالتيبلاينج سيلز الموجودة في الهيومن بودي، فدي ما بتكون فيها إشكالية، لأنه لما اشتغلنا الفارماكوكينetics بتاعته اتضح، والفارماكو داينامكس اتضح انه هو دايما بيكون concentrating في reticular endothelial system. آه،
That's very good. Professor Tajuddin.
السلام عليكم ورحمة الله. ظلال.
وعليكم السلام ورحمة الله. نسمعك بروف
Thank you
تاجدين.
very much. Thank you very much for arranging this very interesting talk. And thank you, Professor Mudawi, for this very interesting and informative and comprehensive talk regarding update of management and vaccination for viral leishmaniasis. Thank you for providing us with this very interesting findings from the clinical trials. And we have learned a lot from the findings of these trials. I hope إن شاء الله تستمر الدراسات العملية و الأذر parasitic diseases والtropical diseases برضها يكون عندها حظ من الكلينيكال ترايل. We have learned from the practical points of these findings, and I would like to ask some questions regarding Professor Mudawi and neurological
Yes.
complications of visceral leishmaniasis, like cerebellitis or cerebellar dysfunction and peripheral neuropathies, mononeuritis multiplex, and other neurological manifestations. Are they reversible? عندنا في الملاريا some patients with severe malaria بيحصل لهم cerebellar dysfunction وبتكون reversible most of the time. And other viral diseases like dengue infection sometimes بيحصل لهم neurological complications such as cerebellitis بتكون reversible. From your experience, are they these neurological complications, are they reversible? الحاجة الثانية I would like to say وأضم صوتي لبروفيسور حبور وبروفيسور سعيد إنه we are facing some difficulties في البريفري بتتمثل في ال unavailability of the diagnostic test. نحن هنا في كسلة most of the time بنكون ما عندنا ال RK39 وبرضه كسلة فيها sporadic cases of viral leishmaniasis، فال RK39 أحيانا يكون ما موجود، والبون مارو اسبيريشن most of the time بيكون ما conclusive، فبتبقى حكاية ال availability of ال diagnostic test في الولايات بتعتبر non-endemic areas for visceral leishmaniasis of paramount importance. Thank you so much.
شكرا جزيلا بروفيسور تاج الدين. وشكرا جزيلا على الكلمات الطيبات. وحقيقة نحن كلنا شايلين الهموم بتاع انه الاكسس سواء كان لميديكيشن او لديagnostics يعني ما بكون موجود اصلا، ودائما بيكون يعني مترتب سبلاي بالذات الميديكيشنز. اما الديagnostic تيست زي الار دي تي زي ما بتكون موجوده اصلا ذاته، يعني دي مشكله كبيره خالص. وانا افتكر دي حاجات الناس المفروض يعني مع وزاره الصحه نشوف انه يعني البروجرام بتاع الان تي ديز بقى في ديبارتمنت الان تي ديز، يشوف انه ممكن يوفر الاشياء دي كيف، لان احنا ات وان تايم كنا قاعدين نجيب الحاجات دي للسنترز من drugs for neglected disease initiatives، لانه هو يعني منظمه supporting us. وبرضه كنا برضه يعني بنستجدي الدبليو اتش او في فترات صعبه جدا، وبواسطه عن بعض الناس اللي بنعرفهم هناك، وتجي عن طريق القاهره وتجي لغايه ما تصل. ولما تصل برضه بتكون بسيطه وتتوزع في الارياف وكده، لانه المنطقة كبيرة جدا والسكان كثيرين خالص، يعني في مستشفيات كثيرة جدا بتعالج أعداد هائلة جدا من العيانين. دي مشكلة حقيقية، مشكلة العلاج ومشكلة التشخيص مشكلة حقيقية. وبعدين حتى مشكلة الانفيزيف تكنيكس التريننج ذاته بقى ما زي زمان طبعا. يعني الناس الواحد بيجي ما بيعرفوا يشوفوا الليشمانيا بسايد بصورة كويسة، لكن دي كلها أشياء المفروض أن الناس بعد ذاك لما إن شاء الله يجوا ويقعدوا في المناطق الحارة مدرمان، يكون عندنا ريفرنس لابوراتوري لازم يدربوا فيه الناس، ونحن وي ار ايبل انه نجيب الناس اللي ممكن يدربوا مايكروسكوبيست. غير كده احنا هو pushing very hard انه يكون عندنا point of care يعني test that can easily be administered حتى ب health worker او باستاذ او بطالب من الطلاب يعني. ودي طبعا هي الشغل اللي لسه جارين ورينا نشوف انه نقدر نشوف الار كي 39 يكون شويه بقى محسن تو كابشر يعني حتى لو انتي بودي تيتر. وبرضه يعني بتحتاج مننا لزمن وصبر شويه، لكن نفتكر if there is a will everything can be done. ودي حاجه كويسه. بالنسبه للنيورولوجيكال مانيفستيشنز كلها reversible immediately مما يحصل ال death of the parasite والانتيجينز خلاص to be cleared by the macrophages طوالي بتمشي، لانه كل الموضوع ده موجود في الميكروغلياز وفي السكوان سيلز وكده، وهذه شوان سيلز. ويمكن يكون discovered زمان بروفيسور داود مصطفى ومامون حميدة وبروفيسور أحمد سنة 94، كان ادى ريبورت كبير جدا. لكن أنا I have seen a case مع دكتورة منى حسين في المناطق الحارة، معنا عمار الطاهر من كلية الطب وبروفيسور الطاهر. كان الكيس بتاع ترو سيريبيلر اتاكسيا، وبعدين ريكفرد بعد ما يتعالج وكده وحاجات زي دي ريكفرد وبقى ما عنده اي حاجه. برضه شفت كيس بتاعت فرانك سايكوزيس، يعني عيانين الواحد بيكون بيقول لك انا اخذت لي قروش حتى ما اخذت لي زول شاله، هو يكون ما عنده قروش ولا اي حاجه، وكلامه كله يعني فرانك سايكوز. لكن اول ما يتعالج كده ما ينتهي العلاج بتلقاه ريكفرد يعني. فبالتالي الحاجه الكويسه انه حتى الليفر فايبروسيس يعني ريكفرز. يعني في بعض الفايبرس تيشو وبيتكون، وقبل ما يبقى فايبروزيس في مرحله الفايبروبلاست قبل ما يبقى فايبرس تيشو يكون فيه زي سيل ديس زي بتاع الشيتوزومايسيس وكده، بيحصل له ريكفري. وده دايما بيكون من الايتو سيلز الموجوده في الليفر، لانه برضه انفولد في الباثوجينيسيس بتاع الليفر في الفيسرال ليشمانايسيس. ف it is من ناحيه الباثولوجي it is a benign disease، يعني العيان لما يتعالج من الفيسرال ليشمانايسيس ما بكون عنده اي ريفرسبل دامج خالص خالص. unfortunately الواحد لما يخش في جوندس I have never seen a case with jaundice who made it. Usually immediately لما يحصل لهم jaundice they develop ascites
وجوندس، ويكون عندهم فيري لو البيومين، مرات بيوصل 1.2، وما بتلقى طريقه ترانسفيوز بالبيومين لانه قاعد في الكونتري سايد وهو بيجي ليت وكده، ويخش في جوندس ويخش في كوما، وطوالي بعد ذاك يعني زي داي. فمشكله كبيره جدا جدا انا افتكر، لانه هو disease of the peripheries، او بعدين في يعني marginalized communities. ووصلوا انه في بعض الناس بيشتروا، بيشيلوا الماضي بتاع الفتايل، وبيشتري له فتيل بتاع الدواء، وبيكسون على الاثنين، وبتم ده مويه مقطره وده مويه مقطره، وبيمشي يطعم بها الناس هناك، في الناس اللي بالذات في ايام الخريف يعني يكون عنده ستوك، وبيطعم بها الناس هناك 2 سي سي 2 سي سي. حتى العيانين بيكلمونا بيقولوا لنا ادوني سيستين سيستين سيستين، وخلاص من غير فحص من غير اي حاجه. وبكون ديفنتلي كلازار، لانه بيكون عندهم خبره كبيره. حتى النساء والامهات بيعرفوا الكلازار اكثر من اطباء في الزول البيئي جديد يعني، بيعرفوا لانه يكون عندها واحد قبل كده جاو كلازار، وواحد بينا جاري جاو كلازار. الاطفال كلازار فيهم واضح جدا جدا. ف أول ما يشوفوه بيدور العلاج. العلاج لما يكون الطرق مقطوعة والخريف وكده، المشكلة إنه the whole family moves with the child. لما يجي المستشفى يكون وقفوا أي حاجة، زراعة بتاعتهم، الرعي، حاجة زي دي، بالتالي بيقعدوا في البيت، وبيجي يطعنوه حبة حبة كده. دي الناس زي بياخدوا صب دوز، والصب دوز ده بعدك بيعمل لنا drug resistance، وبيعمل لنا increasing البوست كلازار ديرمال اشمالايسيس. دي بروبلمز كثيرة جدا جدا يعني كان بي ديسكاس. البيزنس مانايسيس او الاسمايز جنرال محتاجه لكونفرنس، ما تكون هي انكلودد في تروبيكال ديزيزز، عشان بعدها اي زول يقدم حاجه. يكون في كونفرنس عادي، الناس يكون بانل بتاع الديagnostics، بانل بتاع الفاكسينولوجي، وبانل بتاع الدراج تريتمنت، وهكذا. فانا بفتكر انه الناس بيحتاج لايفورت اكبر من اللي احنا هسه بنعمل فيه ده. ربنا يسلمنا ان شاء الله، وربنا يوفقنا جميعا. شكرا جزيلا بروف تاج.
الله يبارك فيك، شكرا جزيلا.
Absolutely, Prof. Mudawi. We need to do much, much more. إن شاء الله ونلم كل الأكسبرتس. دكتور عطية عبد الله، Sudan Country Director for your Global Health and Tropical Disease Expert, please.
طيب، السلام عليكم ورحمة الله تعالى وبركاته. مساء الخير على الجميع. أنا والله سعيد كل السعادة الليلة، عشان تحسوا الإحساس اللي نحن قاعد نحسه برانا لما نكون في انترناشونال كونفرنس، وبروفيسور أحمد مضوي موسى لما يقدم بنقول بالصوت العالي وقدام كل العالم أنا سوداني بكل فخر. فله التحية. دائما رافع راسنا في كل الملمات، في كل التجمعات، ونحن قاعد نفخر به صراحة. في كل مؤتمر الزول بيزيد مترين اللي قدام. أنا كنت سعيد جدا في آخر تكريم في ويرليش، كان نظيم في البرازيل. تكرم مع بروفيسور أبونا الراحل المقيم، ربنا يرحمه ويغفر له أبونا بروفيسور الحسن. إن شاء الله ربنا يجعل كل ما قدموا في ميزان حسناته. أنا والله ما في الليلة ما في كلمات تتقال غير الشكر والتقدير لكم كمنظمين، والشكر والتقدير لبروفيسور موسى كونه بس قاعد حضر المادة دي تحضير يخليك من البرزنتيشن ده جهد عظيم 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 جدا. شكرا لك. دوما انت قاعد تؤلي عملك التنفيذي أهمية، لكن برضو قاعد تدي بالك من طلابك ومن السستينابيلتي بتاعت الليشمانيازي سيرفيسز. شكرا لكم كلكم. وبرضو في يعني زي ما ذكر البروف، في نقاط لسه محتاجة to be discussed more and more and more. لكن الرسالة اللي نحن ممكن نقولها كلنا هسي ونلتزم بها كلنا، يا ريت إنه مسؤولية control and elimination of كالازار و visceral leishmaniasis in Sudan and East Africa هي مسؤولية جمعية، مسؤولية مننا كلنا، من أي زول. الزول اللي قاعد في الحلة، الدكتور اللي قاعد في الاوت بيشنس، النيرس اللي قاعد في العنبر، التراديشنال هيرو اللي قاعد في القريه، كل الناس دي مسؤوليه جمعيه. لانه زي ما ذكر البروف، يعني حتى ناس النيوتريشن، ناس ديوان الزكاه، كل اي زول في السودان، هي دي مسؤوليه جماعيه. ما حنقدر نصل للإليمينيشن الا نحن نتوحد، ناخذ يدنا في يد بعض. شكرا جزيلا مره ثانيه، شكرا جزيلا شكرا جزيلا شكرا جزيلا. السلام عليكم.
شكرا جزيلا دكتور عطية. دكتور عطية طبعا رجل برضه محارب شديد جدا جدا. عرفناه من هو فيري يونج، يعني الحمد لله هسه بقى تروبيكال ميديسن اكسبرت، والحمد لله هو بيقوم برضه بعمل عظيم جدا جدا، ونتمنى له التوفيق. ونحن قاعد نتقابل في محافل كثيرة جدا جدا يعني كلنا، وكانت بتكون أيام سعيدة جدا لما نكون في مؤتمر. يعني الواحد بيحس إنه قاعد في السودان، والحمد لله شكرا لله إنه في يعني يونج جنريشنز برضه مهتمة بالفيسرال ليشمانايسيس. لأنه أنا بتذكر لما كنت فيري يونج وجيت اشتغلت في الليشمانايسيس، ناس زملائي قالوا لي أنت بتضيع في زمانك ساكت. هو دلوقتي خلوني شوية بس. بعدين بعد ما بقيت بروفيسور وبقيت ببلشنج وباخد جرانتس وكده، وليه والله يا اخي نحن ما كنا جايبين خبر، لكن انت في حاله تحسد عليها. ودلوقتي الواحد هو مشى مع البروفيسور احمد محمود الحسن، يعني والدنا زول منتر. يمكن يكون الواحد يعني وجد حظه من الاشراف بصوره دقيقه جدا، يعني apprenticeship يعني مش انك انت بدك حاجه تقراها، وانما is mousing visceral leishmaniasis. leishmaniasis يعني طوال يتحدث ويتحدث لغاية لو في العشاء بيتحدث، لو كنا قاعدين نشرب شاي بيتحدث، لو راكبين في العربية بيتحدث. والحمد لله والشكر لله ربنا يتقبله ويتقبل يعني عمله الكبير اللي عمله في كل الأشياء، مش في الإشمانية بس، وإنما هو أستاذ الأجيال في كل العلوم يعني. الحمد لله. شكرا جزيلا دكتور عطية، الله يبارك فيك.
ألف رحمة ونور بروف الحسن. والمجهودات ما بتروح، هي بتكون مستمرة. إن شاء الله نواصل نسلم الراية وما نقف أبدا لحد ما نصل لزيرو كيسز بإذن الله. It sounds unrealistic لكن with ongoing efforts. And I would like you to share generously your time and devotion with us. Final comment دكتورة نجلاء.
مساء الخير. Thank you for thoughtful lecture. I would like to ask about the cases of neonatal visual leishmaniasis. I heard before about one case just in Sudan. I'd like to know, this is common in Sudan, or there is percentage to care in neonate or not?
وأعلم.
كيس بتاع شنو؟
بعد
سوري
دايرة
معلش.
نفسي.
سوري، السؤال تاني دكتورة
I'd like to
نجلاء.
ask about neonatal visual leishmaniasis.
Oh, okay.
Is it
Very
any
good.
reported
Excellent.
cases in Sudan or not?
Okay. Thank you very much. This is a very good question by the way. يعني احنا قبل ما نجي لعنبر الكلازار في سوبا، بروفيسور الحسن ريبورتد بلاسنتا ليشمانياسيس، وكان المولود طوالي بيطلع عنده فيسرال ليشمانياسيس. ما بيجيه الفيسرال ليشمانياسيس طوالي، لكن بعد 3 شهور إلى 6 شهور بيجيه فيسرال ليشمانياسيس، لكن ما بيطلع هو. يعني لو شلت منه سامبل من بون مارو في اللحظة بتاعته هو طلع، بتلقى عنده آه انت بتلقى عنده باراسايتس، لكن ما بيجيه الكلينيكال سيمبتوم ساينس الا بعد 3 إلى 6 أشهر. كم اللي بيجي في خلال 3 شهور بيجي بعدك يعني يكون صعب جدا جدا. ودائما العيانة أقصد بيكون دائما هي ترانس بلاسنتال ترانسميشن، ودائما الأم بتكون في شهرها التاسع ولا كده بيكون جاها فيسرال ليشمالايسيس وتريتد، لكن خلاص بيكون الترانسميشن حصل. وعشان كده هم شافوا وجدوا فيه ليشمانيال بلاسنتا ليشمانياسيس، وطوالي بعد ذاك راحوا شافوا البون مارو بتاع النيونيت، وجدوا انه فوقه برضه انتي بودي. سم تايمز بيحصل ستيل بيرث. وبعدين اذا كان بالنسبه للبريجنسي والاشمعنايزس دي كلام كويس خالص. اول حاجه the chronic fever usually الكونسبشن ما بيحصل اذا كان الواحده عندها كلازار في الانكوبيشن بيريود، ما بيحصل لها كونسبشن. لكن ممكن الواحده تكون عندها يعني كونسبشن اوريدي، وبعد ذاك يعني 3 شهور او شهرين ولا كده، ويجيها بعد ذاك فيسرال اشمعناز طوالي بيحصل لها ابورشن. في الفيرست 3 months usually كالازار with 3 months pregnancy بيحصل abortion. في بعد 3 months لغاية 7 months ولا كده دول ما عندهم مشكلة. they go on with ال disease. الأم يعني لو جاها في 5 months احتمال تمشي به طوالي، لكن بعد ذلك ممكن يحصل للطفل يحصل له still birth، وبالذات لو كانت في الشهر التاسع. الناس اللي بيطلعوا ويكونوا كويسين على حسب الحاجة اللي أنا شفتها، أنا شفت تو كيسز في الفيلد إنه هم they develop both كالازار dermal leishmaniasis together with visceral leishmaniasis اللي هو اسمه بارا كالازار dermal leishmaniasis. وبعدين أنا شفتهم في الفيلجز، وحتى أنا عرفت فيهم بروفيسور حسن قال لي ديل أصلا بيكونوا حصل لهم transmission from يعني their mothers، لكن you cannot guarantee ذات انه بس حصل لهم ترانسميشن من هناك، لانه برضه بروفيسور ضياء الدين النعيم ورى انه برضه في اندور ترانسميشن. لو في اندور ترانسميشن فبالتالي ممكن برضه العيان، اذا في عيان قاعد موجود في الاسره ممكن to be transmitted الانفكشن to be transmitted للنيونيتس. لكن هم طبعا في فتره النيونيتال بيريود which is 1 month definitely ما بيجوا المستشفى حتى لو كانت في حاجة زي داي ميبي، لكن انفانسي لغاية 1 year بيكونوا دائما بيجوا المستشفى بيجيبوه يعني. برضه ما كثيرين شديد، والكلام ده كويس جدا، لأنه لما جينا نحن في مؤتمر بتاع إنه consultancy meeting عشان develop pediatric formulation قلنا إنه below 1 year or even below 2 years the disease is not common. Maybe because the child is well fed، يعني بيكون ناس هناك طبعا اللاكتيشن بتاعهم بيكون 2 years at least، وما بيحصل له انفكشن. حتى لو حصل انفكشن ربما يعني ما تديفلوب الفول بلون بيكتشر اوف ذا ديزيز. لكن قلنا دائما بعد 2 years the child will be moving around، بيمشي على الفنس، بيمشي على كده، بيمشي على الحاجات دي، بالتالي he can contract the disease outdoors. ولما يصل 4 سنوات بيكون susceptible شيء جدا، لانه بيبقى بيطلع برا على الشارع، وبيبقى في اوت دورز كبيره جدا، خصوصا لو تشوفها على بيلعبوا بالليل. طبعا البيهيفير بتاعت الساند فلاي مشكله كبيره جدا. البيهيفير بتاعتها ان هي بتطير from the sunset لغايه ما الاطفال يتعشوا وكده، وبعدين جنب التجابه وكده بيكون الحته بيطير. لما يجوا هم يدخلوا الناموسيه، لو اديتهم خشوا في الناموسيه بتاعتهم بيكونوا هم already injected by the parasite. وبعدين الصباح بدري بتطير برضه throughout في خلال اليوم. الطيران ما الاكتيفيتي بتاعتها بسيطه جدا جدا. عشان كده نحن يعني لما اتكلمنا عن البيد نتس قلنا انها هي غالبا تكون ما افكتيف، مش لان الانسكتيسايدز فيها مشكله ولا كده، حتى لو الانسكتيسايد كانت اوكي ما في، لكن لانه البيهيفير بتاع الهيومن اللي هناك انه الفتره دي بتاعت المساء فتره الصباح بدري دي بيكونوا ناس صاحيين، وبيكونوا طالعين مع البهايم بتاعاتهم ومع كده وبيمشوا الزراعه، وفي اوت دور واندور ترانسميشن بصوره كبيره جدا جدا. لكن to conclude your question انه neonatal leishmaniasis is not that very common, and if it happens وكانت severe the neonate might die قبل ما يتعرف انه هو سببه شنو وشكله شنو. لكن اذا كان مشى لغايه 6 months 3 months 6 months بعدك المالتيبليكيشن ما بيزيد شويه 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 بتاع الباراسايت لغايه ما يجيه بعد 6 months. لو جاوا فيسرال اشمعنايز ممكن اهله يجيبوه المستشفى لانه بيكون عنده فيفر وكده. لكن الاطفال بتاع 1 months age of age ديل بيكون حتى الفيفر ذاتها ما بتكون تيبيكال، لانه يو نو ذات انه الفيفر في النيونيتس شويه بتحتاج لمونيتورنج بصوره كويسه. ممكن الواحد يكون عنده نيومونيا ما يكون عنده فيفر، اشياء كثيره يعني. فدي اريا بتحتاج لريسيرش يعني، لانه اذا كان في هوسبيتال وفيها اوبسن جاينيكولوجي بصوره منتظمه هناك، طبعا النسوان بيلدوا في الحله يعني ما بيلدوا في المستشفى. فدي برضه واحده من الاشكاليات اللي الناس ممكن تطرقها يعني. شكرا جزيلا.
Thank you.
Much appreciated. Professor Saeed is raising his hand. Please feel free to unmute yourself. Professor Saeed and Professor Ali Habbour.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
Thank you. Thank you very much. Thank you again. I want to comment on Professor Ahmed regarding presentation اللي هو I remember a patient from واد عروة. I think you know واد عروة اللي هي near دوكا. He's a teacher أستاذ عماد.
Yes.
Presented with visceral leishmaniasis and has been number 3 معانا and he developed neuropathy Guillain-Barré syndrome and he improved.
Oh, okay.
Yes, I still remember him. This is about 12 years ago, and he still have a link with him. Ustaz Imad, he's from Abu Urwa near Doka. Yes, and as you mentioned, one of the serious presentation is jaundice. Jaundice,
Yes.
when we found the patient with the jaundice, is horrible. Usually, they have a very poor outcome. Patient presenting with jaundice. Or even develop jaundice as the word is very serious complication should be considered and should be looked carefully. I want to ask Professor Ahmed about these new regimens. What about HIV? Regarding these new combinations.
Yes, promomycin. Okay. Yes. The new regimen of promomycin plus multifocin was tried in Ethiopia because they have a lot of patients with co-infections, HIV, VL co-infection, and the efficacy was around 80%. But you have to have secondary prophylaxis. You have to give them pentamidine every 3 weeks, sometimes 2 weeks, the maintenance therapy, because there is no sterile cure for HIV VL. The parasite will be there, even they don't have fever ولا اي حاجه ما عندهم، حتى الاسبرين بيكون بسيط لانه ما عندهم strong immune response، لانه الاميون ريسبونس هو بيعمل الاورجانوميجالي، هو ميل ديو تو الهايبربليزيا والاكيوميليشن بتاع الماكروفيجز وكده. فديل من الناس اللي يعني المفروض ياخدوا secondary prophylaxis لسببين. عشان ما يحصل له high load of the parasite وبعدين يحصل له ريلابس وريلابس بسيمتومز، لكن هو اوريدي ما بكون عنده يعني الباراسايت ما بكون طلع، ما في سترايل كيور. الحاجه الثانيه هم ديل ريزرفوار فور ذا انفكشن ان ذا كوميونتي. وبعدين على حسب الناس اللي اشتغلوا في ريسيرش في كندا وجدوا انه الاتش اي في في ال الباراسايت هم they are very infectious to الباراسايت very infectious to the sunfly. يعني أول ما تشيل بلط بتشيل طوالي parasite is going to transmit الباراسايت لكمية كبيرة من الناس. ف from a public health perspective أنا أفتكر السكندري prophylaxis مهم جدا. at one time أنا كان مشيت لاتجاه إنه الناس اللي قاعدين في high endemic area of visceral leishmaniasis المفروض يدوم primary prophylaxis especially in Ethiopia، لانه اذا كان ما في جود مونيتورنج لناس البلد وناس يتعاملوا بامواس الحلاقه مع بعض وكده. if you observe الحكايه دي المفروض تعمل primary prophylaxis اللي هو انت قبل ما يجيك هو بيصل للشمنايسيس you have to give them some treatment. واقترحنا انه المالتيفوسين ده ذاته ممكن يكون واحد من التريتمنتس اللي انت ممكن تعمل به primary prophylaxis، وبالتالي بتكون العيان بتاع الاتش اي في ما حيجيه فيسرال ليشمانايسيس، لانه اذا كان فيسرال ليشمانايسيس فيال كو انفكشن بيبقى مشكله كبيره جدا جدا. وبعدين لما تعالجوا ذاتهم بيحصل لهم ايريز واللي هي
الاميون ريكونستيتيوشن انفلاماتوري سيندروم، وده بيجيهم في شكل سكين راش اللي هو البوسكولازار ديرمال ليشمانياسيس. ففي كومبليكيشنز كثيره جدا. ف ال الستدي ورت انه 80% هم هسه they will include it in the guidelines for treatment of HIV/VL co-infection، ولكن برضو عندنا مشكلة بتاعت الريلابس. دي مشكلة. أنا بتذكر كنت في University of York، وكنت شغال في مستشفى كاسل هيل هوسبيتال، ومعروف كنت هناك أنا اكسبرت في الاشمعنايسيس وكده. فجابوا لي في العيادة محولة عيان عنده HIV/VL وبياخد في مالتوفوسين، وقال هو يعني اللود الباراسايت لود بتاعه لما شافوا له هو بقى بسيط جدا لكن ما خلص نهائيا. فقالوا وات دو يو ثينك، لانه هو خايف انه تجيبه كومبليكيشنز من ال- الملتفوسين. فانا اي ستوب الملتفوسين لانه بعد ذلك لما تدي فرصه للمالتيبليكيشن لفتره من الزمن، يعني ما ياخذوا طوالي، ياخذوا بشكل سايكلز، لانه ما خايف من انه ممكن يحصل ترانسميشن للناس التانيين، لانه ما في ساند فلاي هناك. فدي واحده من الاشياء اللي برضه مهمه جدا، انه عشان في انجلترا ما في ساند فلايز، فبالتالي الا بعد ذلك طبعا ترانسميشن عن طريق البلاد ولا حاجه دي ما ممكن يحصل اصلا، لانه هناك الناس بيكونوا مرتبين جدا جدا. و لكن عشان ما تخط العيان في دراج هو ما بيحتاج له، هو ما عنده فيفر، ما عنده كده، ما عنده سيمتومز بتاعت ليشمانايسيس، لكن عنده فيو باراسايتس، والفيو باراسايتس دي اصلا ما بينتهوا يعني خالص خالص، لانه ما في استيرايد كيور زي ما قلت لك. فبالتالي هي ستوب الميديكيشن وخليته ياخذ سايكل بعد سايكل، يعني 1 month سايكل يفوت 1 month وثاني ياخذ سايكل 1 month وهكذا. فبقت بالنسبه له زي السكندري بروفيلاكسيس. شكرا
That's
بروف سعيد.
great. بروفيسور علي حبور.
والله going back to النيونيتال ليشمانيا. الحقيقة بالنسبة للنيونيتال ليشمانيا ممكن بيشبه الكونجنيتال مالاريا. نحن بالنسبة لنا كونجنيتال مالاريا is very clear، يعني عندنا
Yes.
two types، في كونجنيتال مالاريا وفي نيونيتال مالاريا. الديفينيشن بتاع الكونجنيتال مالاريا هي discovery of malaria in the first week of life. after that لغاية 28 يوم بتكون insect
أيوة.
infected malaria. لكن نحن هنا we rely more on غير البلاد فيلم، الاي جي ام والبي سي ار. ما اعرف راي ناس البروفيسور في انه نحن we do not accept congenital malaria الا يكون في positive serum اي جي ام. فما اعرف هم رايهم شنو. وانا افتكر انه اي طفل او اي نيونات في الاريا ديك عنده فيبر انا ليشمانيا should be considered، وحقوا الناس يشوفوها. لو شافوا 3 4 حالات يعملوا لهم السيروم اي جي ام او البي سي ار if it is used in the discovery of congenital leishmania or not. لكن بالنسبة لنا في الملاريا الأمور واضحة جدا. I have never seen a case of congenital leishmania over the last 40 years ولا حاجة زي دي في السودان يعني.
الو.
Yes,
أيوة.
we hear you.
الو.
We can hear you, Your Excellency. Hello.
اوكي. سو بروفيسور علي حبور كان بيسأل من بروفيسور علي حبور كان بيسأل من ما سمعت الكلام في الآخر، لكن هم يعني في الملاريا they rely on IgM
And he also stated never coming across congenital leishmania in
I
40 years plus practice.
عملوا برضه فور مالاريا ولا لا بروفيسور علي؟ مم. وطبعا الكونجنتال مالاريا اقصد ليشمانايسيس هو ترانسميشن اللي هي في بلاسنتال ليشمانايسيس، وموجود هسه في ريبورتد في السبلمنت بتاع بروفيسور الحسن اللي هو ليشمانايسيس السودان ببلش 2001. ولكن مهم جدا انه البرزنتيشن بتاع في النيونيتس مرات قد يكون انفكتد هو ترانسبلاسنتالي، لكن ما يحصل له clinical symptoms and signs لانه الانكيبيشن بيريود بتاعت الليشمانياسيس is not يعني short like the malaria. فقد هتاخد يعني فترة من الزمن حتى بعد ذلك تجيه clinical symptoms and signs. You need some time for the parasite to multiply to reach a specific threshold, and then it's going to cause you or the unit to cause the unit some symptoms. It depends whether the child or so the unit is heavily parasitized ولا هو يا دوبك يعني استقبل الانفكشن من البلاسينتا. لو استقبل الانفكشن من البلاسينتا بالتالي بيكون الكميه بتاعت الباراسايت اللي هو الدوز اوف ذا باراسايت از سمول، فبالتالي it might take time months and weeks عشان يحصل multiplication وبعد ذاك يحصل انه to develop يعني you need to develop ال clinical symptoms and signs كده commonly. حتى لو كان transplacental infection بيكون دائما بيجي في خلال الشهر الثالث او الشهر الرابع. انا غاية الناس شفتهم الايف دائما في الشهر الثالث والشهر الرابع، شفتهم كان عندهم visceral leishmaniasis plus post calazar dermal leishmaniasis، لكن 1 month of age usually they die اذا كانوا heavily parasitized، وبالتالي بيكون قبل ما الناس تديسكفر في الهوم، قبل ما تديسكفر انه العيان ده عنده شنو هو بيكون اوريدي يعني دايد وكده. فدي واحده من التشالنجز برضه، وتحتاج لاكسبلوريشن definitely.
Thank you so much, Your Excellency, Professor Ahmed Mudawi. Two final questions, and then we'll let you go. I know you're a very busy man, and we do appreciate your time. Question is, renal impairment due to sodium stibogluconate, is it reversible? And the second question is, when to switch to the second line due to liver impairment or high liver enzymes without co-infection of viral hepatitis?
Sorry, the second question is
When to switch to second line treatment in case of liver impairment with high enzymes without co-infection with viral hepatitis.
okay, very good question. طيب الكويشن الاول طبعا اول حاجه العيانين ديل بيكون عندهم liver derangement due to visceral leishmaniasis itself. When you push SSG, some of them they might develop some renal impairment لكن reversible، لانه الريجنريشن في الرينال سيستم is available، ما بيحصل fibrosis في الفتره بتاعتي. فبالتالي الفيسرال ليشمانايسيس التوكسيسيتي بتاعت الرينال سيستم من البنتوستام is reversible. لكن البروبلم الكبيره لما ندي صوديوم ستيبوغلوكونيت بلس بروماميسين، ونحن اشتغلنا دراج انتراكشن وجدنا انه البروماميسين increases the level of SSG لكن ما بالطريقه الكبيره شديد يعني، لكن ده من ناحيه دراج انتراكشن. المشكله كلها انه مرات البروماميسين هو نيفروتوكسيك and اوتوتوكسيك، والريفرسبيليتي is very difficult عند اذا كانت التوكسيسيتي كانت due to او الاوتوتوكسيسيتي كانت due to بروماميسين.
فالفيسرال ليشمانايسيس can cause deafness, nerve deafness، لأنه بيتأثر على cranial nerves برضو. ولكن الأمينوسيدين أمينو جلايكوسايد باراميسين برضو causes the same thing. ونحن عندنا patients and I remember patients لغاية ما جينا ركبنا له سماعة حتى جبناه الخرطوم هنا، كان معنا في التريل ومزورين منه نحن طبعا لغاية يعني ما حصل له deafness. والديفنس بتاعه discovered بعد ما هو يعني وصل لغاية قرب يكمل ال 17 يوم من العلاج، وبقى ما بيسمع كويس. و stop the treatment، وبعد ذاك طوالي بديناه امبيزوم، لكن ما ريكفرد بصوره كويسه. لكن كثير من الناس بيقول لك بيحس لك بيقول لك انا يطني سنا او ما بسمع كويس فتره من الزمن، ودي بتكون دائما ريفرسبل. لكن لما يحصل severe damage ما بكون ريفرسبل، especially في ال في النيرف deafness. فدي واحدة من الأشياء المهمة إن البرومايسين is not free of renal or ototoxicity. الحاجة الثانية بالنسبة للترانسامينيزز، الترانسامينيزز إذا كانت بقت 5 fold you have to I have to shift to another medication 5 fold. يعني إذا كان قلنا مثلا إذا استعملت أنت هنا التست والكت اوف بتاعه كان 40 او 45، بالتالي اذا وصل اعلى من 200 you have to exclude العيان من الاس اس جي. فدي واحده من الاشياء برضو المهمه، لانه اذا بقى 5 فولد اساسا احنا ما بندخله في الترايل لما جينا، ده كان excluded. ولكن هسه في الريل لايف ابلكيشن لما يكون عندنا عيان جاب سيفير جوندس هاي ترانسامينيزز لايك مثلا 300 وكده، نحن وي شيفت التريتمنت طوالي ل امبيزوم which is يعني السايد افكتس حقته very negligible، يعني ما في مشكله. I hope I managed to answer the question.
Perfectly. Thank you so much, Your Excellency, Professor Ahmed Mudawi Musa. It was very insightful and inspiring, as well as challenging lecture for all of us to carry on with research work. And on behalf of Tropical Disease Hospital, we're willing and able to carry on with research. And we have good cohort of patients attending our services. Allow me to thank you on the behalf of Tropical Disease Teaching Hospital Academic Club, the organizing committee, دكتور سارة عمر الطيب، دكتور لاي عمر ريح، دكتورة أمل أحمد سوار الذهب، دكتورة ريان تنجة، دكتورة تقوى سعيد. It was a pleasure to have you with us today. It's truly inspiring, your lifelong dedication to research and scientific work. We're very grateful. And despite your many, many national and international responsibilities and the ministry work as well, you generously devoted your time and your vast experience with us today. Finally, thank you to all the participants. And inshallah, this will encourage us for further research, stronger collaborations, and commitment to improve prevention, diagnosis, treatment, and eventually elimination of visceral leishmaniasis or leishmaniasis. Thank you so much. Final words, Professor Ahmed Mudawi.
شكرا جزيلا دكتورة ظلال على الجود انترو يعني closing. وأشكركم كلكم والله. and I have never seen such a dedicated team يعني. وبعدين very receptive وبيحلوا مشاكل كثيرة يعني. Well, I'm very glad to be one of this collection. ويعني I will be at hand at any time. Don't worry at all. I can manage my time very well. No problem at all. In fact, whenever I see younger generations shouldering this responsibility, I admire them so much. And I hope that we meet face to face, we discuss, we treat, and we mentor each other, inshallah. شكرا جزيلا بروفيسور علي حبور، شكرا جزيلا بروفيسور سعيد، شكرا جزيلا بروفيسور التاج.
على يعني صبركم معنا في فترة هذه المحاضرة. وأنا يعني أعرف تماما بروفيسور علي حبور من يعني ما شاء الله ما شاء الله، نحن عيانين كلهم بنحولهم لبروفيسور علي حبور من منطقتنا هناك منطقة الحلاوين. ويعني رجل قامة، ونتمنى له يعني دوام صحة والعافية، ربنا يحفظه ويحفظ عائلته إن شاء الله. اشتغلت هاوس اوفيسر في مدني بعد ما تخرجت من الخرطوم، واشتغلت هناك الوقت ده كان بروفيسور علي حبور موجود في اللواء 20. وكانت فترة جميلة جدا، عدينا فيها سنتين في مدني، اشتغلنا مع كل الأخصائيين. اشتغلنا في الأطفال، أنا اشتغلت مع بروفيسور حسن، اللي هو بسموه حسن صبا عليه رحمة الله. اشتغلت مع بروفيسور عثمان
رحمة الله
طه.
عليك.
اشتغلت بعد ذاك مع كمية كبيرة من الأخصائيين في مستشفى مدني، مستر أحمد الأمين الشيخ، بروفيسور دكتور سعد النعيم عليه رحمة الله، ودكتور سالم،
الرحمن على
هو
السلام.
علي سالم. وكان يعني دائما معانا ناس، بروفيسور آه، جبريل، عبد الله عبد الكريم جبريل،
والله عبد الكريم.
وجاسترونترولوجيست عبد الله عبد الكريم جبريل،
اسمع
وقبل
خلف
يومين
الله.
كنت بتهاتف معاهم. بس ما خلف الله يس. وكانت عندنا ايام جميله خالص، وكان بيرسلنا بروفيسور بروفيسور عثمان طه، كان بيرسلنا لفاروق الامير عشان نشوف
يس.
معاه الاكس راي يشرح لنا وكده. وانا كان سلكتد
ايوه.
اوف سيرجري جامعه الجزيره. في جامعه الجزيره سلكتد ريجسترار، كنت هاوس اوفيسر بتاع ناس محمد الامام وفيصل نقد والجماعه ديل. لكن بعد ذاك طلعت مشيت بفتش على انه الواحد لميت في بروفيسور احمد، وبعد ذاك قعدت معاه لغايه ما الواحد الحمد لله يمكن البوزيشن بتاعه ما بطال يعني. أنا سعيد جدا جدا، وهذه الجلسة عادت لنا يعني أيام جميلة جدا جدا، كانت في مدني وكانت في شرق السودان وفي القضارف. وأتمنى إنه يعني الناس تكون دائما متعاونة مترابطة، وإن شاء الله أنا at hand at any time. وشكرا جزيلا لكم، وما بقدر أعبر والله عن فرحتي بأنه يعني قدرت أوصل صوتي لكم، والناس استفادت منه يعني إن شاء الله. شكرا لكم.
شكرا جزيلا. نتمنى زيارة قريبة في مدني، عشان تشوف
إن
الديفلوبمنت
شاء
اللي
الله.
حصل في الكيوريتيف ميديسين في مدينة مدني إن شاء الله، وتزورنا في جامعة
إن شاء
الجزيرة،
الله
ومرحب بك.
definitely definitely إن شاء الله.
جزاكم
so
الله.
planning إن شاء الله شهر 8 إن شاء الله.
جزاكم الله عنا كل خير أساتذتنا البروفات. We find you very inspiring, and we know tropical diseases have been neglected for a long time. We're just trying to touch base and kind of raise awareness on tropical diseases just to spread the word. Thank you so much, all the participants. بكل مقاماتكم السامية. Thank you, our colleagues, for your convenience. We post our links. Follow for more updates. Lectures are still ongoing on the Leishmaniasis scientific series. And yeah, just follow the links to find all the scientific material available for you whenever. Sarah Tayyib to conclude. And thank you so much. Have a lovely evening.
Thank you so much, my partner in crime. I think there's nothing left to say. This was one of the memorable sessions, of course, in our humble platform. And I feel that we are always honored to be among such amazing Sudanese figures and astonishing physicians. And today, of course, we've had the chance to learn and get a lot of knowledge from His Excellency. I think this is a great pleasure, a memory, a core memory in 2026, of course. And thank you to all our esteemed guests and our panel of experts for always being with us in each and every session, supporting us and teaching us more and more about tropical diseases and fighting for the Sudanese people in able to maybe in the near future, inshallah, to conquer the tropical diseases that we have in our country. Thank you so much again for the participants as well for staying this long with us. And thank you to all my colleagues in the Tropical Club. On behalf of all of them, we thank you once again. زي ما دايما بنقول إلى أن نلتقي مرة أخرى. أبقوا عافية and have a great night. Thank you so much.
شكرا جزيلا، شكرا لكم، السلام عليكم.
عليكم السلام ورحمة الله.
في أمان الله،
عليكم
لا
السلام.
نلتقي. السلام عليكم.